mutation is there, you won't use imatinib. The cost is a bar, or is the comorbidity is preventing you from using the other TKIs. Apart from that, I don't think there's any other reason why should not be changing it to second generation TKI rather than increasing the dose.
Yeah, so the data on this is that if you escalate to 800, you might be able to overcome resistance in some patients who have primary resistance. And increasing dose of imatinib is difficult to tolerate. And it works only in patients who experience some cytogenetic response. And this response is normally not very long lasting, so you may need to consider that. And for patients who have hematological failure or who've never had any cytogenetic response to 400 milligrams of imatinib per day, they are very unlikely to respond to 600, 800. And then you have to kind of treat them with a second generation TKIs. So we are lucky and fortunate that we have several second generation TKIs now, generic versions available to us. And that option is now opened up to us.
But previous we have some patients who have been on 600 and 800. They didn't do well with the 400, but some of them have done really well on 600. So we still
I
have
agree
some
with you, Dinesh. Patients in that GPAP cohort, and lots of us have lots of patients in that cohort. I was looking at my data of, I think, 500 patients. About 10 to 15% of my patients, at least, who have not shown an optimal molecular response to 400 have gone into an optimal response with increase of dose to 600, 800. Very small number tolerate 800, but some almost do tolerate 600, right? Do you agree?
Yeah,
So
I agree.
those must be, sir, low resistance mutation on the kinase. All the more reason to do the NGS to know the low resistance mutation. And 600, if you give, these patients will respond beautifully.
So I completely agree with you, Ajay. Theoretically, that is fine, but for a patient of on GPAP on Gleevec in the GPAP program, it is tough enough to get a BCR-able testing RT-PCR done. So it's even more difficult to get a NGS done, which is a lot more expensive. So these are some phase 2-3 results of second line use of TKIs in patients. Obviously, the response in patients who are resistant is a little less than patients who are intolerant, but you have dasatinib over here, 7-year follow-up. You can achieve a major molecular response in about 50% of patients. And similarly with imatinib also, about 2/3 of the patients can have a prolonged PFS and OS and can have a complete cytogenetic response. This correlates to a major molecular response. And similarly with bosutinib and much higher rates with ponatinib. And again, as for first-line TKIs in the de novo CML CP patient, if you achieve response, a BCR able less than 10% at 3 months or 6 months, then the survival outcomes are much better as compared to if you do not have a BCR able less than 10% at 3 months, and sometimes this is a cohort of patients which have a dismal response even to second-line treatment, whether you have used dasatinib or you've used nilotinib. Toxicity is extremely important, and we know that the choice of treatment depends upon the toxicity. And I think all of you are aware of the toxicity. All of you are aware about the dosing. And this certainly needs to be kept in mind. There are some now long-term emerging renal effects of imatinib which are coming up, so you need to monitor the serum creatinine at least once in 6 months in patients who are on imatinib for a long time. Vascular events with nilotinib, again, they are between 10 and 20%. They seem to be, slightly increasing as time goes on. So you really truly need to counsel your patient who's on long-term nilotinib about exercise, about diet and everything. You need to be careful about pulmonary hypertension in patients of dasatinib. Bosutinib appears to have the least long-term effects, but still the follow-up period is much less. It's been around for a shorter period of time. And with ponatinib, we are of course aware of the vascular events, which has led to a dose reduction in first line as well as in second line. And this, I think, again, is an important factor which we need to consider, the TKI and drug interactions. Other than imatinib, it's not advisable to give proton pump inhibitors or H2 blockers also, not to be given with bosutinib, dasatinib, nilotinib, and ponatinib. It produces a major difference in blood levels all the three groups, PPIs, H2 blockers, antacids, some interaction with antidepressants, and cardiac medications. Again, you have to be very, very careful. Most of them have a problem. Most of the TKIs have a problem. Our patient was on Verapamil, so I would be very hesitant to use nilotinib in this patient. It is advised to avoid. And if I were to choose, go back to patient number one, then I would choose bosutinib, which would probably be the safest in this patient. So continue the TKI and drug interaction. I think this has to be hammered into all physicians who treat CML. And there are major interactions with anti-infectives, antifungals, with the fluoroquinolones, and herbal supplements. I think quite a lot of our patients take curcumin. And then again, across the board, all the 5 TKIs, these are the 4 which are available to us. There is increase in exposure if one of these things are combined with our TKI. So it is very strongly advised that the patients don't take this when they are taking your TKI, particularly if they are responding. So stay-at-home messages, optimal second line, subsequent line treatment for patients with CML depends on several factors: kinase domain mutations, treatment used in the first line, age and medical comorbidities, and toxicities of the previous treatment. So if we have time, we'll quickly go through this. This is a 48-year-old teacher, CML CP 2012, intermediate focal risk. Did not achieve a major molecular response at 6 months of imatinib, shifted to nilotinib, did not achieve a major molecular response after 6 months to nilotinib, changed to dasatinib, no major molecular response at 6 months. Fully compliant patient, no kinase domain mutations found, at least on Sanger, refuses for allogeneic transplant. So my question first to Dr. Chirag is, Chirag, quick answer. How frequently do you see patients like this in say 100 patients of CML-CP? How many of those are resistant to 2 or 3 TKIs? Resistant in the sense that they don't show a major molecular response. Dr. Chirag?
So I cannot give you exact number, but it's a significant number who don't achieve MMR, and yet they continue to do well on a stable PCR. A lot of our GPAP patients even on imatinib alone. So it's fairly common.
So Dr. Avinash, what do you do for these patients who don't show a major molecular response to 2 or 3 TKIs?
Yeah, actually, these are the candidates who should be going on with Ponatinib if it is available, allogeneic stem cell transplantation, Asimetinib, and if not, in my practice, I go back to drugs like interferon alpha or hydroxyurea or busulfan. For me, the answer first given was ideal answer. In practice, what I do is to go back to the previous drugs which are not used. This is a bad situation. Hemant, can you give me 1 minute?
Yes.
Regarding the change of TKI at the suboptimal response at 6 months, there is a recent study by Tkis called as Dasson study, who has said that if you do not change and continue imatinib, and he has got follow-up of 30 months, he said that it makes no difference in PFS or overall survival, whether you change to second generation or remain on imatinib. You will get early molecular responses, but they do not translate into overall survival. So in a non-avoiding patients, I even continue imatinib beyond 12 months, etc. What else one can do?
So that holds true for 3 months also, Avinash. Descent.
Yeah, and I think all of us have a whole bunch of patients in the GPAP program in which you have no other choice, and they are still continuing, not being in major molecular response in BCR-able between 1 and 10, but they continue for years and years and years. Yes. So I think a lot more study and data is needed on this. I completely agree with you, Avinash. Okay, so in a patient like this, would you continue the TKI or would you completely stop the TKI? Very quick answer. Avinash, you again.
Yes, I will continue TKI.
Correct. So there are several
patients must be on TKI till the whole of their life, whether they are responding, not responding. That is the rule.
Correct. So, there are clones which are being suppressed by the TKI. I normally shift to the cheapest possible TKI, which is imatinib, and then try to control the splenomegaly and the blood counts by adding one by one other drugs. So this patient had a hematological response in 2018. He required this whole bunch of medications to control him. Like he had to be given 6-MP, oral etoposide, small dose of steroids, in all of them together, and continued imatinib. And then, with the availability of bosutinib, we started him on bosutinib. We could taper off all the other agents one by one. He is in hematological response, but we are still very carefully awaiting the molecular response. We'll get it done after 3 months. And we, eagerly await the asciminib, and if the asciminib trial comes to us, then we will put this patient on asciminib. So Dinesh, if you get the trial, please tell me. I have 1 or 2 patients absolutely ready for you.
So far nothing has come back.
So this is data of bosutinib in the third line, and you can see that incidences of major molecular response can be up to 33% at 2 years and 45% at 5 years. So we really welcome the availability of bosutinib in the country, and this is a little bit of the same. And these are the various novel treatment options which are available to us. The leading option is asciminib. There are other TKIs, redotinib, which is available in Korea. The Aurora kinase inhibitors, the FTI inhibitors, the JAK2 inhibitors in combination.
Can I request one thing? We
Yes,
have a
please.
very effective allogeneic transplant too. So we have the young patient. The Western guidelines may not suggest this because most of the patients are elderly, but I think we have a very effective transplant option too. Someone who has a sibling MASD, we should encourage someone who has failed multiple things and possible for the transplant because the one-time expenditure and curative option.
100% agree with you, Dinesh. If you have the right patient, it is mandatory for
As you said, don't forget the old drugs. Don't forget the transplant too.
Yeah. And I'm, particularly fascinated about another novel drug, which again is off-label. So a disclaimer about that is the addition of pioglitazone to one of the TKIs. And we have a, small series of 15 odd patients who've done quite well on that. So the take-home message is for the second patient, second case, 5% patients are poor responders, mechanisms are poorly understood, not entirely mediated through kinase domain mutations. About 10 to 40% patients may respond to a new TKI. It's worth trying one by one, all the three available to us in sequence. A higher response to Ponatinib, and we await the arrival of this drug in our country. And of course, we await imatinib and the studies with imatinib. And this is the point that Dinesh was making. Stem cell transplant must be kept in mind for the eligible patients. So any very quick 5-second response by each of my panelists. Ajay, second line treatment.
Yeah,
Dr. Hemant, I think this French study of pioglitazone should be discussed a little more if possible. We have about 8 patients in about 1.5 to 2 years. They've all gone to complete remission. So about 8 out of 10 patients went into complete remission after adding pioglitazone.
So Chirag, I think quite a lot of us are aware of that. Quite a lot of us are using that. And in fact, Dr. Vikram Matthews and Vellore has applied to the ICMR for a formal phase 3 study. I'm not aware of what progress happened for that trial, whether they got approval or not, but it is really seriously being thought of in our country also. And, I would like to suggest that maybe we can pool our data and, that would, give weight to the effectivity. So any last comments from you, Rishabh?
Nothing to add, sir.
Thank you. Great. Anybody else has any comments before we wind up and hand over back to the organizers?
Yeah,
I think, sir, I want to comment.
Yes,
so
Ajay.
that
Very quickly, 5 seconds.
so in the CML also the time has come when we need to combine the two drugs of different pathways. So that will eventually break the ice.
Yes, it's an interesting concept. Anybody has any other last final parting comment?
I got a simple basic comment that
Yes,
if your aim is survival of the patient, any TKI is good. Do not bother about molecular parameters going up and down. If your target is to go for a treatment-free remission or pregnancy, etc., think of going for second generation TKI. But if you are having imatinib with cytogenetic remission, that is enough. Those patients will live as long as they can normally. That's all.
Very well said. Completely agree. Any last words from you, Dinesh?
I agree with your take-home messages, sir.
Thank you very much. So I think let's make SMS our habit. And this is my last slide. My respects and regards to Dr. Advani again and to Dr. Parikh. Great initiative, and I'm really happy that you chose CML as the first topic. It's an area of interest of mine, and very happy to be able to contribute to this. So the best home is home, the best age is courage, the best smile is smile, the best stand is understand, the best end is friend. And Dr. Parikh, happy birthday again, and the best day is today. So have a wonderful day. Thank you very much.
Thank you so much, sir.
Thank you. Thank you very much.
We'll move to our next session. This session is sponsored by AstraZeneca. The panel discussion is on how I manage CLL with recent advances. Our moderator is Dr. Suprakash Sanyal, hemato-oncologist from Mumbai. His panelists are Dr. Rajesh Patil, hemato-oncologist from Mumbai, Dr. Dipanjan Haldar, hemato-oncologist from Mumbai, Dr. Abhijit Behati, hemato-oncologist from Pune, Dr. Nilesh Vasekar, hematologist from Nasik. Sanyal sir, with your permission, I will share your slides.
Yeah, sure. So next. So next. Yeah. So good afternoon, everyone. So we just go through the two cases with my esteemed panelists. Thank you, Dr. Advani and Dr. Thapalik, for this beautiful opportunity provided. So this gentleman is a 74-year-old male, presents with a cervical lymphadenopathy with comorbidities like hypertension, dyslipidemia, and prostatic hypertrophy. Extensive bulky node in the neck, axillary, and the groin. CBC is reasonable. Hemoglobin is 11.1. WBC is 88,000 with 90% lymphocytes. Platelet count is 104,000. So flow cytometry confirms CLL diagnosis. Marrow is around 70% is replacement with CLL. CT scan revealed widespread adenopathy with large node. So it's more than 10 centimeter in the mesentery and 8 centimeter in retroperitoneum. FISH testing revealed deletion 11q and IgHV is unmuted status. So quick question to Nilesh. What is your treatment of choice for this patient?
Thank you so much, sir. I think he's an elderly gentleman, 74 years with comorbidities like hypertension and high cholesterol. Here, I would give an option of B plus R as well as ibrutinib to him because a lot of data is coming up for survival as well as PFS benefit with ibrutinib. And I think going ahead with if a patient is okay, I'll give the option of both the drugs, ibrutinib or bendamustine plus rituximab here.
Yeah, Dipanjan, any other thought process?
Yeah, so my only difference in opinion will be I'd probably give option of ibrutinib first, and the second choice, if it is financially feasible, would be acalabrutinib plus minus obinutuzumab or venetoclax plus minus obinutuzumab. B plus I will push lower down because for the simple reason the patient is elderly patient, and so my first choice will definitely be lone therapy with oral therapy ibrutinib.
Nilesh? Sorry, Rajesh, sorry.
Yeah, sir, actually the lymph node size in CT scan is quite big. Maybe to rule out richer transformation, I will get a PET scan and might get a biopsy of that area to see whether the transformation has happened. And if
not transformed. It is not transformed.
If it is not transformed, then I think that we'll continue with the same options what Dr. Dipanjan and Dr. Nilesh said.
Yeah. Dr. Abhijit?
Yes, I completely agree. So I'll prefer ibrutinib over the BR because of this IgHV unmutated. And with the availability of the generic ibrutinib, I don't think the cost will be matter. So definitely we should push for the ibrutinib in the present scenario. Even though it's a rise stage 2, with the lymph node size of 12 centimeter, is a candidate for the treatment.
Yeah. So bottom line is very clear. He needs treatment due to the bulkiness of the disease. Choice will be the 74-year-old elderly with a not badly comorbid, but he's still comorbid. So oral therapy will be always score over the intravenous therapy, and the oral therapy is obviously the Dr. Abhijit told that the generics are available. So ibrutinib is a very reasonable choice for this group of patient. Next. So when we discuss about the CLL treatment with the family, we definitely take consideration about the FISH study and also the IGHV mutation status, therapeutic options available, oral versus intravenous, definite versus indefinite, and obviously we talk about the newer therapies. Next. So there are two basic things we should always do before starting the treatment, and one is the IGHV mutation status, because that matters, because the prognosis is significantly different from the mutated and unmutated status. And number two, the FISH study. Next. So we all know that deletion 17p and deletion 11q is considered to be the worst prognosis. Generally, around 75 to 80% patients, you can get some form of FISH abnormalities from their peripheral blood screening. FISH is to be done preferably at the onset of the diagnosis, and whenever you start your treatment, at point of time, you should always repeat, because it can change in sometimes, because it's a heterogeneous disease. Immunoglobulin heavy chain mutation status don't change. So once you're done, you are done, and that is the status, is the final for the patient. Next. So many elderly patients with a CLL are considered unfit for intensive therapies and still have limited therapeutic option due to the greater incidence and severity of the comorbidities with the age. And there remains a need for treatment options with a favorable safety profile, which is extremely important for this group of patients, can be personalized based on patients' comorbidities and other factors. Next. Dipanjan, I want just quick comment from you regarding the CLL11 with a obinutuzumab plus chlorambucil versus rituximab with chlorambucil from your practice point of view. Whether you offer rituximab chlorambucil in the old population and how you go about.
Sir, so previously I was offering rituximab chlorambucil to elderly population, but nowadays I think with generic ibrutinib being available easily, so my practice has changed over the last few years. So nowadays for elderly population, definitely my choice is ibrutinib monotherapy. In elderly population especially, I do not combine ibrutinib with rituximab because of no significant benefit and the high risk of infections in such patient. So for elderly population, definitely my choice of therapy now is ibrutinib monotherapy. And with obinutuzumab, frankly speaking, I do not have much experience.
Vijit, your thought process?
Yeah, same. Yes, sir. Same. I agree with Dipanjan. So preferably ibrutinib. It's convenient for patient, and cost-wise, not much difference now.
Nilesh? Nilesh?
Nilesh, sir, you'll have to unmute your mic.
Yeah. I do give an option to a patient's family that if they want to continue a long treatment or they want a 6-month treatment and then follow. So if they are choosing with B plus R 6-month therapy, I'm going ahead with that. Or I'm also giving the option of ibrutinib. But I tell them that you need to continue it for long.
I think it is extremely important point, because you choose definite versus indefinite treatment. I think I fully agree with Nilesh's point that this is extremely important, and little families' idea is also very important. Rajesh, your thought process?
Yes, sir. But in recent years, since the ibrutinib has available as generic, I think the people are more ready to take an oral drug. So recently, we are offering mainly ibrutinib. Previously, we have used rituximab chlorambucil in some patients.
Yeah. So slowly, when we are talking about an availability of the ibrutinib is in the market with a much cheaper rate, our practice is shifting towards the ibrutinib monotherapy than rituximab chlorambucil. Obinutuzumab chlorambucil I used for the 2 patients. One patient tolerated well, another patient has a lot of cytopenia and pneumonia. So I was not very personally happy in my practice with OB chlorambucil combination. Next. So, Dipanjan, little bit about venetoclax or obinutuzumab.
So definitely venetoclax.
If you get venetoclax also cheaper rate.
Yes. So definitely it is a very acceptable combination. The main advantage in this is again a definite therapy versus ibrutinib, which is monotherapy, which is an indefinite period of therapy. So venetoclax, obinutuzumab, again a targeted therapy, less of side effects compared to conventional chemotherapy, and the response rates are also quite good. most importantly, compared to ibrutinib monotherapy, it is again a definite period of therapy.
Yeah. So bottom line is the oral versus intravenous. Cost is a complex issue because you have to continue for long, and again the definite versus indefinite treatment. So all these three things to be cleared with the patient very clearly, discussed with in detail, and then to take a call how to go about. Next slide. Next. So now we come to the RESONATE-2, which is a long-term efficacy and safety of the first-line ibrutinib treatment of the patient with CLL SLL. So it's a 5-year follow-up study, and 5-year progression-free survival is 70%, which is relatively good one. Nilesh, your comment a little bit about RESONATE-2.
Yeah, though the PFS is very good, but some patients like around in this study around 14 to 15% patient have left ibrutinib because of side effects. That thing also we should keep in mind, like atrial fibrillation, bleeding tendencies, and infections. Because of that, some patients could not tolerate ibrutinib. Though the PFS is very beautiful, but at the same time we should look at side effects also.
Correct. I fully agree with you. So next slides, we'll discuss a little bit about that. So next slide, please. Yeah. Next slide. Yeah. So of the patient who experienced grade 3, more than grade 3 major hemorrhages, around 67% were taking concomitant anticoagulation treatment. So bleeding, atrial fibrillation, and hypertension. So these three are the three major side effects of the ibrutinib. There are some minor side effects like headache, diarrhea, skin rash, and the joint pain, cup muscle pains, so all are there. But one thing in our practice is very interesting about ibrutinib. All the problems, what we hiccup, the most of the time is the first 6 months of the treatment. So once you cross that first 6 months, 1 year gap, then mostly patient tolerated well, and then it become a cakewalk for the patient. But yes, patient has to understand these side effects because though they're not much in number, but they are problematic. So Neeraj, personal experience of any bad bleeding, bad atrial fibrillation in your practice so far?
Yeah. One of my patient had bleeding, and that too, he had gut upper GI bleeding. So he required endoscopic intervention, and but he was not on in concomitant anticoagulant drug also, and I had to reduce the dose. After that, he settled. But yeah, that was a bad experience for me, bleeding.
Dipanjan, anything for you? Bad one?
So yes, I did have a patient of atrial fibrillation, but we did not have to interrupt ibrutinib. The atrial fibrillation we could manage successfully if the patient did not require anticoagulation.
Abhijit, anything for you?
Yeah, so we have this, other than this, like we have 2 cases of this tumor lysis, but that was like manageable, but not like a hemorrhage.
So nothing extremely bad.
Yeah.
Rajesh, anything for you?
No, sir, no significant.
Rajesh is happy with ibrutinib. Next. So discontinuation of the treatment due to the adverse events occur less frequently in ibrutinib group than in the acalabrutinib group. So that is interesting. 9% versus 23%. Hypertension observed around 15% patient of the ibrutinib, but they did not require any discontinuation or dose reduction. Atrial fibrillation was managed with discontinuation in 2 patients in RESONATE trial and without dose modification the remaining 6 patients in the ibrutinib treated group. Bleeding, major bleeding occurring in the 4% of ibrutinib and 2% of the acalabrutinib patients lead to discontinuation in 3 ibrutinib treated patients. So bottom line, side effects are there. They should be informed to the patient very clearly. Not much in number, but when it happens, you have to intervene. Most important thing, after the median follow-up of 60 months, 41% of the ibrutinib treated patients had discontinued treatment. The same data what we see in the imatinib trial in the long back. Dose reduction due to any adverse event occurred in 27 patients. But most important, the adverse event related treatment discontinuation ibrutinib decreased over time. So 7% of the patient in year 0 to 1, 6% in 1 to 2, and that become only 1% in year 4 to 5. So that is very important, that you have to continue the treatment, you have to manage the side effects, then down the line, the life will be easy. Next. So this is the real world clinical experience. Up to 23% of the patient discontinued frontline ibrutinib due to adverse events. So toxicity, yes. Progression of the disease is 7%. Death happens in 9%, and other causes is also around 11%. So 50% patient more or less stick to the ibrutinib treatment for long term. Next. So there is another drug which is a elder brother of the ibrutinib, which is the acalabrutinib, which is a more selective covalent second generation BTK inhibitor, approved in August 2019, indicated for relapsed refractory mantle cell lymphoma and frontline and relapsed refractory CLL. It has a more specific BTK inhibitor and associated with limited off-target effects in the preclinical studies, which make the drug more attractable in view of less side effects profile. Next. So this approval is basically on the Elevate-TN trial. So Nilesh, want to comment a little bit about the Elevate-TN trial?
Yes, sir. It was a beautifully designed trial, and there was clear-cut benefit of using acalabrutinib with or without obinutuzumab over obinutuzumab with chlorambucil. And the side effect profile of acalabrutinib was better than ibrutinib. Also, there was PFS benefit in that arm. So even if you are using acalabrutinib with or without obinutuzumab, it is acceptable for those patients. So I think acalabrutinib is a good option for CLL, frontline CLL.
So this trial is very nicely designed, what Nilesh told. It's a acal mono plus acal obinutuzumab plus obinutuzumab chlorambucil. 2 years progression-free survival is 93% for acal mono, 87% with the acal combination, and 43% with the obinutuzumab chlorambucil group. And overall response is 94% with the acal combo versus 86% acal mono and 79% of the obinutuzumab chlorambucil group. Most important benefit is a progression-free survival, and it is consistent across the all patient subgroup. That is the most important thing. Next. So that is the same graph which shows that progression-free survival benefit with consistent with all across all the subgroup. Next. Next. So side effect profile about this Elevate-TN trial. So if you see the side effect profile, that you can get the headache and diarrhea is the very common side effect. Cytopenia is also happens. But the side effects of the atrial fibrillation and the bleeding combination is extremely rare with the acal combination, acal combination. Next. So that makes this drug, acal or acal obinutuzumab, is a category 1 recommendation in the NCCN guideline, CLL, SLL, preferred regimen. Next, both in the older patient and younger patient. So now we go to the another case, which is a relapsed refractory CLL. So next case. Yeah. So he is a 74-year-old male, presented with a wet loss, fever, and night sweats. So B symptoms present. Patient was diagnosed with CLL at 63 years of age and was treated with FCR for 6 cycles and was symptom-free for last 9 years. So he did very well with FCR for almost a decade. So now the white blood cell count has gone up, 45,000 to 79% lymphocytes, hemoglobin 11, platelet count 140. Fish is trisomy 12 and deletion 17p. So dreadly cytogenetics is back. IGHV unmutated. And so this patient definitely needs treatment. So what will be the most appropriate management for this patient? Rajesh.
Yeah. So considering his age and 17p positivity and availability of ibrutinib will be the most appropriate drug to start in this. Other than that, venetoclax and the coming acalabrutinib will be the option.
So Rajesh, quick question. If you have both the option, ibrutinib and acal, what do you choose? Finances.
Yeah, acalabrutinib will choose because the chances of tolerance and continuation is more with acalabrutinib.
Dipanjan, your choice? Finance is not an issue.
Yeah, so if finance is not an issue, I will also go with acalabrutinib. Number one reason is tolerability is better. And number two is progression-free survival, 93% with acal versus 70% with ibrutinib.
Nilesh, you are the city of the grapes. So money is not a problem. Tell me.
Yeah. As Dipanjan and Rajesh said, I think I will also go ahead with Acalabrutinib if finances is not an issue. Yeah.
So Abhijit?
Yes, sir. Completely agree with this.
Tell me.
Yeah, I agree with this. We can go with Acal.
Yeah. So bottom line is very clear. Old patient, relapsed refractory setting, oral treatment. We want a very less side effect compared to and we want to continue the treatment. That is another most important thing. And definitely in the side effect profile, Acal will be always be scoring over the Ibrutinib due to the adverse side effect profile. Next. So this is a resonant study. Ibrutinib versus Ufatumumab in high-risk relapsed refractory patients. Long-term follow-up data, efficacy results. So Nilesh, anything you want to comment?
Yeah, it was a beautifully designed study, and Ibrutinib had a upper hand over Ofatumumab, which is hardly used now. So it was beautifully designed, and we can clearly see there was a PFS benefit to Ibrutinib over a long period of time. Yeah.
So bottom line, we are preferring the oral treatment, and we are preferring the oral treatment with less side effects. So whatever the scenario, BTK inhibitor is one of the most important platform of this treatment of the relapsed refractory setting. Next. So these are already we discussed. Next. So resonance study safety profile. So if you can see from this beautiful graph that grade 5 is extremely rare. That is the grade 1 is a grade 5. So pneumonia is the only grade 5 side effect. Grade 4 is also not much. The neutropenia and the thrombocytopenia is a grade 4. Otherwise, all the side effects what we see is either grade 1, mostly grade 1, grade 2, and grade 3. So this is reasonably well tolerated. Safety profile is also reasonably good. So that is the reason the entire practice is now slowly shifting towards a BTK inhibitor. Next. So a little bit away from the BTK inhibitor, we now just discuss a little bit about the Murano study. So Murano study is basically a time-limited study. That is the most important thing. We are discussing a little bit about the time frame. So sustained benefit of time-limited venetoclax plus rituximab in relapsed refractory CLL. So this study design is also very good. So venetoclax and rituximab for 6 cycle, and then venetoclax for 2 years versus 6 cycle of the BR. And there is significant amount of the progression-free survival and overall survival benefit. Dipanjan, any comments?
No, I think already covered. So venetoclax plus rituximab is a very attractive option for definite therapy for relapse refractory as well as newly diagnosed patients.
Avijit, your comment?
Yes, sir. This venetoclax plus rituximab, and even that sometimes we can add the ibrutinib in that combination in some cases of refractory cases.
Absolutely. So double oral drug, right?
Yeah.
Yeah, and the most powerful 2 drug. Next. So that we already discussed. So it definitely has a PFS and overall survival benefit. Next. So this is the Murano safety data. Murano safety data is also relatively an efficacy data, which is also relatively well accepted. Next. Next. So now we discussed a little bit about the Ascent trial, which is basically a trial, phase 3 randomized open label trial, which shows the efficacy and safety of the Acalabrutinib versus investigator choice. So choice is rituximab idelalisib or rituximab bendamustine in relapsed refractory setting of the CLL. Avijit, little bit of your comments.
Yes, sir. There's significant difference with the PFS and with this Acal group compared to this other, even though the targeted therapy. So definitely the benefit is there with the Acal.
So absolutely. So if you see the median follow-up of 16 months, so you see the Acal significantly prolonged the IRC assessed progression-free survival. There is almost 70% reduction in the risk in progression and the death. And the most important thing, that overall response rate is not significantly different across the group. Next. So headache and diarrhea and neutropenia is the most common side effects of this study. And next. So this is the group of the subgroup of the patient, and progression-free survival is definitely much better, but overall survival is not significantly different. And treatment discontinuation due to adverse event in the study in ACAL group is around 10 to 11%. Next. So this is a graph of the overall survival between the ACAL versus the ibrutinib and the BR. Next. So incidence of events of clinical interest, you can see that atrial fibrillation and hypertension happens, but not very much significant here. Next. So these are the most common side effects. And among the entire side effect range, you can see the headache is the thing which is manageable. And we all know that BTK causes some amount of headache, muscle pain, and all this stuff. But slowly, when you continue a treatment, it subsided over a point of time. Sometimes it may be nagging. You may need to give some low dose steroid. Sometimes it helps. But if you manage 5-6 months down the line, everything is taken care of very nicely. Next. So these are the 2020 EHA ISMO guideline for the CLL treatment. You can see that everywhere is the relapsed CLL, everywhere is the ibrutinib, ACAL. The BTK is finding their place. Venetoclax is also very close competitor about this two drug. And I think the coming era will be a hard competition between the ibrutinib versus venetoclax. And what Avijit told, that combination of these two probably can be a good, wiser way to go forward. Next. So this is again NCCN guideline with the NCCN guideline. So ACAL and ibrutinib and the venetoclax rituximab, these are the category 1 recommendation. Next. So this is again the relapse category. Relapse category again the ACAL, ibrutinib and venetoclax rituximab. So these are the treatment options which are very novel treatment options. These are actually much away from the rituximab chlorambucil, rituximab bendamustine. So all this conventional chemo-based regimen to more novel, more selective treatment-based regimen we are moving. Next. So if I summarize the whole thing, deletion 17p or T315i mutation is considered a high risk. Deletion 11q IgG unmutated, elevated beta-2 microglobulin, complex karyotype are the unfavorable. Chemotherapy is actually no role in the management of the relapsed refractory CLL patient in current era. Deletion 11q and the unmutated IgHV are unfavorable prognostic marker. Newer novel therapies, BTK inhibitors are coming in big way in the current standard first-line therapy for high-risk CLL patient with deletion 17p and BTKI plus minus monoclonal CD20 preferred regimen to treat high-risk relapsed refractory CLL patients. So Dipanjan, any comments? Dipanjan?
Dipanjan, sir.
Sorry, I got muted. Sorry, yeah.
Yeah, yes, go ahead, Nilesh, go ahead.
My phone was disconnected. Sir, can you repeat it?
Yeah, so any comments about the whole thing? So we are moving towards now BTK era, right? So
yeah, right. So I think this era is a beautiful era of BTK in CLL management. But still, I would discuss with the family that really you want to go ahead with a long-term therapy or a short-term therapy. I'll give option of BR still today. That because if you see the overall survival data also, when BR is still, though it is down in the line, but I will not hesitate in giving the option because it's available in MJPJY also now, and I cannot give ibrutinib in MJPJY. So still BR will be there for 17p non-deleted patients or IgHV mutated patients, elderly, and other patients definitely BTK inhibitor I will go ahead with.
I think except that small subgroup of patients who are very young, fit, non-deletion 17p, and then the IgG, HBB mutated status, these are the group of the patient. Probably they are the FCR is the best part of the treatment because you can give a cure to them. Otherwise, all subgroup of the patient, BTK inhibitor is playing a very major role in today's world. But what Nilesh was saying is absolutely correct, because many families are absolutely correct because they're budgeting everything depending on the fixed duration of the treatment. So that way, BR is still a reasonable option if the patient can tolerate. I fully agree with you. Dipanjan, your thought process?
Yeah, so I completely agree with all the panelists. I think one particular challenge that I'm facing now is still quite unmet is patients resistant to ibrutinib. So that part, we do have got a few patients who are resistant to ibrutinib, whose disease is progressing on ibrutinib. So for such patients, treatment option left is practically only like they're 17p positive. So treatment option left is venetoclax, which practically is out of bound of cost for most of the patients. So that is still one unmet need in our scenario, and probably we once the generic venetoclax, if it is available down the line, probably that need definitely needs to be met.
Vijay, your comments?
Yes, I completely agree with this. And one more thing about these chronic diseases, like while commenting or while accepting newer drugs, we always have to see the how much it is translated into overall survival. Because though significant PFS is there, but if it is not translating the overall survival, then we have to consider the other factor like finances. And because before giving the options, we have to understand this patient financial and the socioeconomic status. So this OS is also very important while deciding the treatment option.
I fully agree with you. In our private practice, it's absolutely very important thing. Yeah, Rajesh?
Yes, sir. I agree with you. What you said, young patients, non-deletion 17p, and want spinal treatment, I generally go for BR, and others who wants to take a long-term, are ready to take long-term treatment, and finance is not an issue, will prefer BTK inhibitor, either Ibru or as Acala is available, then Acala.
So thank you. So we are just concluding our panel discussion here. Probably, I think we are in time.
Perfect. Thank you very much indeed. Perfectly on time.
Thank you so much, sir. We'll move on to our next session. Our moderator is Dr. Shripad Banavali, medical and hemato-oncologist from Mumbai. His panelists are Dr. Irappa Madhabhavi, medical and hemato-oncologist from Bagalkot, Dr. Gaurav Narula, hemato-oncologist from Mumbai, Dr. Tulika Sheth, hemato-oncologist from New Delhi, Dr. Shweta Lukkand, hematologist from Pune, Colonel Rajan Kapoor, hemato-oncologist from Delhi. Shripad sir, please note, Govind sir will join us soon. Over to you, sir. Shripad sir, you'll have to unmute your mic. So can you hear me?
Yeah, sorry.
Yeah, no worries.
Thank you. Can I share my slides?
Yes, sir, please go ahead.
Can you see the slides?
No, we can only see you.
Not yet, sir.
You will have to click the green button called share screen at the bottom.
Yeah.
Now we can see your screen.
Okay, great. Thank you. So, I've been given the topic of covering the special circumstances in CML. And, yesterday we heard Dr. Advani, we heard Dr. Purvesh. That's why I think I feel my credential as student and ex-chief resident of Advani, Dr. Advani are better than maybe my credentials today, because we really had a great time and really learned a lot from Dr. Advani. And Purvesh was my colleague there. Purvesh, myself, and Charak, like Dr. Purvesh told yesterday, we had a great time at that time. So you heard about the panelists. I have Dr. Gaurav, Dr. Govind, Dr. Irappa, Dr. Rajan, Dr. Shweta has joined, and Dr. Tulika Sheth. So these are the panelists on this panel discussion. And before starting the topic, I thought I'll just give some background information, because that's more related to what personally to me and maybe even to Purvesh. So this, the chromosome, the Philadelphia chromosome, was initially diagnosed, or at least published. It was diagnosed maybe in 59 but published first time in Journal of National Cancer Institute way back in 1960, the year that I was born actually. So that has some special this thing for me. And this was the first genetic defect linked to a specific human cancer, and it changed the direction of cancer research and definitely has paved the way for development of new targeted therapies. So this was something that personally for me, because it was when I was born the same year. The other thing is Janet Rowley later, as we know, who was at the University of Chicago, identified the mechanisms by which this PH chromosome arises as a translocation. So though it was diagnosed or identified first by Nowell and Hungerford, Dr. Janet Rowley actually first showed how the translocation occurs. And later in 1998, this was again important because this was the year I think that I joined Tata Hospital as a resident along with Dr. Purvesh, when the molecular genetics of PH chromosome started to come, and it was published in New England Journal way back in 1988. And it was important because that was the time when Dr. Advani used to always tell us that, this is what the future is going to be and molecular is going to be the future. And, some of us definitely questioned it at that time. But now we know that everything that we are doing today is linked to the molecular mechanisms of various cancers. And again, the first time the tyrosine kinase being an important part of this whole process was initially showed way back in 1990, the year actually that we left Tata and went to US. So basically, the history of CML has some personal touch for me. So I thought I'll give that. But coming to the special circumstances, and the first thing I thought we cover 5 or 6 circumstances, and let's see how much time we have and how we go about it. The first thing is, do we really, I think some of it was discussed yesterday, but does one really need to do a bone marrow in all newly diagnosed patients of CML, and what is the importance of that? Dr. Irappa, if you can start with you.
Yes. Good afternoon, sir. Am I audible?
A little
Hello?
faint, can you just...
Sir. Now,
Yeah,
sir?
better now.
Sir. We need to do bone marrow in all patients, all newly diagnosed CML patients, because bone marrow will show the morphology of the disease, and we will know the percentage of blast cells and percentage of basophils, which actually distinguish AP from CP disease, CML CP disease. And cytogenetics, it will identify the additional cytogenic clonal chromosomal abnormality also in PH positive cells. And sometimes, if you get any dry type from the bone marrow aspiration, you need to go for bone marrow core biopsy also. It will show the percentage of fibrosis and will do it has prognostic significance. And sometimes nests of cells which are not identified in the peripheral cells, that will distinguish blast phase from CML.
So, do you think the bone marrow blasts are different from the blast in the peripheral? Does the blast percentage differ in the bone marrow in CML, or the bone marrow is a mirror image of peripheral blood?
Bone marrow is a mirror image, but sometimes if it is overloaded with CML cells, glomerulocytes, basophils, you cannot distinguish basically percentage of basophils and blood cells. Actually, percentage for distinguishing between AP and CP.
So like you told, to do the cytogenetics is one of the important tests, and we discussed about it a lot yesterday. So what is your approach in the presence of additional chromosomal abnormalities in the marrow? Does the treatment differ? Do you do anything differently, or how do you take that into consideration?
Additional cytogenetic abnormalities constitute around 8 to 9% of the total CML cases, and we need to identify the high risk or low risk cytogenetic abnormalities. Some of the high risk abnormalities have poor prognostic effect on the disease outcomes, like trisomy 8, isochromosome 17, extra PH chromosome, trisomy 17, 19, 21, and low risk one which have less significance as compared to high risk. So that we need to identify it, and we have to see the and the high risk patients, high risk CA patients have less response to the conventional TKI. We need to intensify the treatment sometimes. And in one of the CML4 study sub-analysis, so only complete cytogenetic response at 6 months is around 65% compared to without any ACs.
So you will intensify the treatment if there are more.
Yes, sir. Like we need to change it to second generation TKI if we started with Ponatinib. And
Okay.
yes.
Okay. So Gaurav, we do bone marrow, but what about flow cytometry? Should one do flow cytometry in all newly diagnosed patients of CML? And if yes, how can we justify that? Dr. Narula? Hello? Gaurav, can you unmute? We can't hear you.
Yes, my unmute was disabled, I
Sorry,
think,
sorry.
by some error in the thing. So I just managed to do that now. So, sir, that's a very interesting question you ask. It's definitely not a standard recommendation, but it's a thought-provoking one. There is data that shows that the presence of abnormal lymphoid blasts, especially in even a low level of such blasts in a diagnostic marrow or otherwise chronic phase CML, they do tend to develop sudden blast crisis very early into their treatment when no other indications are there that they might do so by the traditional methods. So, while the WHO criteria itself is silent on this, how to classify such patients, our own study, albeit a retrospective one, which was recently published in Cytometry, showed that how 3 out of 5 patients with abnormal lymphoid blasts were able to rapidly progress to sudden blast crisis within the first year itself of treatment. So I think it's a question which needs to be looked at more carefully in a prospective manner. Definitely in pediatric CML, which tends to behave biologically slightly more differently than the adult CML, probably it's a question worth looking at. So I think it's something which should be explored. We could not say that it should be a standard recommendation for everybody right now, but it's a question which needs to go into.
Because we always see case reports and publications in the literature, especially in pediatrics, where you see sudden development of blast crisis, and otherwise children were doing okay. And now this we found, like Gaurav told, that 3 out of 5 and now 4 out of 6 who have developed blast crisis within short time. Very interestingly, actually, if there is a population of myeloid blast crisis, they have not done poorly or they have not transformed into blast crisis. But the patients who have had abnormal lymphoid blast clone, and that what happens in flow is you can analyze nearly 1 million cells. And then if you see the small, even a very small clone, I think these are the ones who have not done well. So maybe in the future that may be important. And another one which I had done actually, that was my first paper, or it was the project on which I went to US to work on, which we had shown way back in 1990, that basically if you have more CD34 positive cells in the bone marrow at diagnosis, in the marrow or peripheral blood actually, but if you have more CD34 positive cells, these are the ones who go into accelerated and blast crisis. So even CD34 estimation at the time of diagnosis may be an important thing to identify a subgroup of people who are not doing well. So that's something to be considered, maybe like Dr. Gaurav told, in the future to do. And Dr. Govind Babu joined in?
Not yet.
Not. So maybe Dr. Tulika Shet can take this question. Tulika,
Yes.
what is your approach in the presence of atypical transcripts? Do you do anything differently?
Well, we monitor them with fish because often it's easier to do that. And of course, we need to monitor them closely. because they may not do as well as some of the traditional patients, but the monitoring is basically the major impediment that we find.
So you would like to know that upfront, and it may help you to monitor these patients. That's good. So maybe, you know, one thing which I think has not been covered in this meeting, and which was applicable for this special circumstances, pregnancy in chronic myeloid leukemia, and now especially that we know many of these patients are going to live for years and years, and basically pregnancy would be an important aspect during some type of the treatment. I think this is becoming an important topic for, especially for CML in even pediatric CML who later become young adults. So what advice do you, this question, Dr. Shweta, if you can take this question. So what advice do you give young patients on TKI who desire to plan a family?
Firstly, I would like to thank you, sir, Dr. Banavli and Dr. Purvish, sir, for this opportunity. And going ahead with the answer, I think for all the young patients on TKIs who want to plan a family, the first and the most important advice is that it should be a planned pregnancy. It should not just happen accidentally, so that during the period of conception and during the period of the actual pregnancy, TKIs can be stopped and patients can be monitored for the same. Secondly, whenever a young patient is planned for a TKI therapy, I would prefer to start them on a second generation of TKI rather than a first generation of TKI, for the simple reason that we can achieve a major molecular response faster, and maybe we can give them a TKI free period during the pregnancy, and hence it will be easier for them to plan their pregnancy. Also, before considering the choice of TKI, I will take into account the SOCAL score and the comorbidities of the patient. That is it.
Dr. Tulika, you know, especially young females, because, you know, we also see very often now asking about pregnancy and this thing, childbirth. So how do you plan treatment in young female patients who desire to have a child, Dr. Tulika?
So I think Shweta already highlighted some of the important issues. What we do is we do a lot of counseling, and we know that all the TKIs, because of their off-target PDGFR toxicity, they can lead to major side effects like hydrops and teratogenicity. So we counsel all our families that they should stop the TKI before they get pregnant. And what we do,
How much time before?
so often actually what we tell the family is that when you're thinking about getting pregnant, you should let us know and stop, because obviously we do not know the day that they're going to get pregnant. So this is the ideal scenario. And we do have some families who do this, and we will monitor them, make sure that they're in an MMR before we stop the TKI. And if we feel that they are at risk for progression, we'll switch them to interferon before they actually get pregnant. So this is the ideal scenario. The real life scenario is that most of the time the woman will come and say, I'm pregnant and I've been taking my TKI, in which case then we obviously have to stop the TKI at that time, send them to the OBS people, get an ultrasound. Occasionally we have recommended termination of pregnancy if they have been taking it for their first trimester, several weeks or months. If they are very early on and the ultrasound is safe, again, we counsel them, we tell them that we don't know what the outcome is going to be, because there is data of safe pregnancies, but the data is very limited and scanty. And there's no recommendations for TKI safety in the first trimester. There is some data in the second and third trimester where people have used TKI, but the ELN 2020 says that, again, that data is not sufficient evidence and it should not be routine practice. So we recommend interferon, and we're lucky that we have this Janani Suraksha Karikram, and most of our patients being BPL, and they can get interferon throughout pregnancy. The other thing that often people forget is that TKIs are also contraindicated for breastfeeding. So you need to ensure that the interferon, if that is what you're using for somebody who's not an MMR, should be continued during the period of breastfeeding, and then only patients can go on to the GPAP program again. And the GPAP program has actually been very kind, and even though these patients are off the medicine for a long time, they allow them to be re-enrolled again afterwards.
So maybe you are right, because most of the data that comes out in literature is the cases where there are problems and all. So if some of especially the adult people who are looking after CML, whether they can form a group or at least every patient who gets pregnant during treatment, whether it's during ongoing TKI or without, maybe there should be a record kept or a group who can collate all this data. It may be really good for the community and for even for international per se.
So I just wanted to say that with the interferon scheme that we have been doing, because every time a woman in the reproductive age group comes, we talk to them. And I remember the last time I was talking, this woman, she put up her hand like this and she said, "Nay, I've already had 3 kids with interferon," and she followed all the things and she had 3 healthy children. So it's very
Great.
possible.
Great. What about, just to finish it off, what about in male patients? How do you advise a male patient of CML?
The ELN guidelines has actually put this controversy to rest. So except for Ponatinib and Asciminib, where we don't have too much data, the ELN 2020 says for males, there is no need to stop the usual TKIs that we use, either the first generation or second generation. But as I said, Ponatinib and Asciminib, we don't have too much data. So we don't tell them to stop.
No, but what about that before conceiving? Is it important to hold for some time, or it doesn't matter whether the
there is some, you're right, there is some data on, at least for imatinib, saying that sperm count can decrease. And we're actually doing a study at the moment on that as well. But again, the ELL 2020 says that if the sperm count decreases, it then stabilizes. So the ELN 2020 doesn't say that you need to stop it, though that was our practice before.
Okay. So maybe the other thing which nowadays, yesterday you heard Dr. Advani mention, and when we practiced in way back in the 80s, most of the patients will enter this blast crisis, and we used to really get scared of this when this would happen, which is very rare, but I think still that's why it's become a special circumstance now. So maybe we should touch a little bit on the CML blast crisis, and especially it happens in those who are treating ALL as well as CML, and especially young people, where we see many times patients who come, initially diagnosed as Ph positive ALL, but we know that all Ph positive ALLs are not so, and some of them are actually CML lymphoid blast crisis. So Dr. Shweta, how do you diagnose a newly diagnosed case of Ph positive ALL to actually, make a difference to tell that this is not Ph positive ALL but CML blast crisis, and does it matter in management of these patients?
So firstly, I think we should go stepwise. The clinical history of the patient, like if there is a long history of abdominal distension and splenomegaly, or if there is a very chronic insidious course of the patient, then it might be a marker that this might be a patient who is having CML blast crisis. Then secondly, the peripheral smear of the patient. If the patient is having a concomitant myeloid differentiation, shift to left, neutrophilia, basophilia, then these might be markers that this could be a patient who is having CML blast crisis. Thereafter, when we are examining the patient, as I said, splenomegaly again, a very significant, a very massive splenomegaly could be a marker that this could be a CML patient. Then when we send the BCR-ABL, the transcript type, it is not a definite rule, but mostly it has been seen that transcript 210 is more common with CML and transcript 190 is more common with ALL. But as I said, this is not a hard and fast rule. Again, in CML, the PH chromosome is present in all the metaphases, in non-malignant cells, in the B cells, in the T cells, in the myeloid cells. However, in ALL or in acute leukemias, it is not such a case. Similarly, when we order for the MDS related mutations on the multiplex ligation probes, these MDS related or leukemia related mutations would be absent in a CML cases, and CDKN2A and 2B gene deletions will be more common with the acute leukemia rather than with the CML. So eventually, actually, it is going to be a more experienced guess rather than a foolproof way of diagnosing whether this is a ALL or a CML. But these are the points which can help us to diagnose whether it is a CML or a ALL. Next, as you, yes, sir.
Yeah, does your lab do a lab score? Do you all do
Yes,
lab
sir.
score
Yes,
routinely in a
yes,
lab?
yes,
Will that be
yes, sir.
helpful for?
Sir, lab score is usually decreased in a CML, but again in a blast crisis, I don't think it will help much.
So not during the blast crisis, but if once they achieve remission, if the lab
Yes,
score, you are
yes,
right. In
yes.
blast crisis, the lab score is not important. But once
Yes,
you
sir.
achieve a remission, if the lab score is low, I think that
Yes,
may
sir.
be a simple test,
Yes,
especially in
yes,
the lab,
yes,
to help you out.
yes, yes.
Mm.
So as
Yes,
per
sir.
the yes, sir.
No, please go on.
No, no, sir, please.
Oh, okay. No, I was just saying that further to what Sir had also added, that as they say, the best judge of a person is not by the clothes they wear, but by the way they behave. And the best way to judge a CMLBC from a PH-ALL is also by the way it behaves. And we often find that these patients, after induction, intensive chemotherapy, which may be started for PH-positive ALL, they don't respond the way you would expect ALL to respond. So that is and they're often not in remission at all at the end of induction. They're induction failures, so they behave that way rather than like an ALL. Sorry, do go on. I didn't mean to interrupt
Yes,
you.
sir. Yes, sir.
Tulika, do you manage these patients differently?
So definitely, I think a CML lymphoid blast crisis, we are going to be, the induction may be similar, but then these are patients that we will definitely make sure that they go on to transplant as early as possible. We know that pH positive ALL patients, not all of them need transplant. And, so these are patients that we would want to move on to transplant soon, because especially the kinds of patients that I have where if it's a short-lived CML-CP that happens after the blast crisis on a second-generation TKI, we won't be able to take them very rapidly. So transplant definitely for pH-positive ALL, but most definitely for CML-BC, because we don't get patients who can afford the more expensive TKIs.
No. Hello. Yes. Sorry, I missed the last part. But maybe we'll go to the next area, and that is basically treatment-free remissions. Because this is another thing that is becoming important now, that many of our patients are on this drug for years. So, Dr. Rajan, basically, what do you practice treatment-free remissions, and what are the main barriers for practicing this?
Yeah, good afternoon, sir. Before I answer, I'll just tell you where I practice. Where I practice, Imatinib is given free of cost to other second generation. But the monitoring, we generally outsource and they have to pay out of their pocket.
Okay.
And Dr. Gaurav Narula and Dr. Purvish Parikh will know that not only our patients, our doctors also move length and breadth of the country. So we do try TFR. This is a buzzword. So we are having a trial which we have enrolled around 10 patients. Now I'll come to the second part. Like main barriers is picking up the right patient. As I said, our patients, maybe the serving soldiers which we have, who are doing very well. So the criteria are well known that they have to be on imatinib for 5 years and more than 2 years in the deep molecular response. The main thing is convincing them. They say that if I'm doing so well, why should I stop? I just have to pop one pill. And somehow in army, when we start them on imatinib and CML, they get sort of a sheltered appointment. So they say that if I'm off drug, I won't be given a sheltered appointment also. So there's one particular area, convincing patient whether they should they should leave a drug which is doing so well, their quality of life is good. That is the main barrier. Second barrier which we face is monitoring. Now, as we are aware, it has been well talked that whenever we have to do TFR, we have to do a very close monitoring from a lab which we believe in. Because here is a disease which is absolutely under control. It's become a chronic disease, and we don't want a patient to progress into a blast crisis. So you have to do a monthly BCR ABLs for 6 months and then carry on doing for a long time. So that is the main barrier. Third, obviously, is sometimes when they leave TKIs, we have seen in a couple of patients having those withdrawal syndromes. Now, one group which we find is the most encouraging is the ladies, as we have just discussed, the ladies who want to conceive. They are the most forthcoming. They keep on asking whether we can stop the drug and conceive. So this is the group of the patient which we target the most, which can go for TFR. And second are the younger patients who have got a long life ahead. They are the ones who are motivated enough. So these are the main challenges which we are facing in practicing TFI. It's a very encouraging concept. We know that 60%, 50-60% can be off drugs, but challenges will remain in our country. I'm sure other panelists also would share the same view.
Maybe is Dr. Govind Babu, has Govind Babu joined? If not,
No,
maybe
sir.
Dr. So just last, maybe Dr. Tulika, if you can complete it. So maybe in your practice, what are the eligibility criteria you use, and basically how many of your patients you can stop the treatment?
So again, we have a limitation of the GPAP patients that we have not been doing the TFR because they will not be able to be re-enrolled. But we do have patients who are affording patients and they purchase the drugs. So patients who have either been on a second generation TKI and for at least 2 years and have reached an MR4, 4.5, or have been on imatinib for 7 to 8 years. And we know that they have had a good so-called score to start off with. They were compliant. They reached all their landmarks on time. So these have been a few of the patients that we have attempted. The main problem has been during the COVID times. We didn't start anybody on this, and we had a few patients who were not doing their monitoring regularly. So that is definitely a problem, but we're lucky, at least in the metros where we have good, reliable labs and they can do monthly monitoring. So as the first speaker had said today, TFR during COVID times has been an issue, but we do have patients, and now the ELN 2020 has set out the criteria. So I think most people are following those criteria.
Okay, I can see Kashish here, so maybe I think our time is up. But I wanted to cover basically the pediatric questions. Dr. Gaurav was there, but I think we are short of time. So maybe I'll just end up by, yesterday we heard Dr. Advani present the patient, and as he told, when we were residents, 95 or 97% of our CML patients will die. But this is a very important quote which was given by Mr. actually. He's Mr. Charles Kettering of the famous Memorial Sloan Kettering fame, basically, who told us way back again in 1960s that the doctors tell us that there are certain diseases that are incurable. Do you know what an incurable disease is? It's the ones that the doctors don't know anything about. The disease has no objection to being cured. And I think this is what has happened to CML, because, right from the time I was a resident, this was an incurable disease like many others, like Burkitt's and, the M3's promyelocytic leukemias. These have become so curable now that I think once we know how to treat them, most of the diseases which are incurable today will be cured. So best of luck to all the younger generation, and I hope that there are many more cures like we have now for CML. Thank you very much, and back to you, Kashish. Thank you all the panelists for being there. I'm sorry I couldn't cover some of the areas that we had thought of, but maybe at some other time. Thank you very much, and back to you, Kashish and Dr. Purvish.
Thank you so much, sir, for the wonderful session. I now request Dr. Parekh to please introduce the next session.
Thank you very much. This is the session in 2 parts, and it is the Dr. Smita Advani Memorial Oral Paper Competition. We had the elimination round yesterday before the main conference started. And today we will have the finals in which there are 3 in the first session and 3 in the second session. So total 6 abstracts that have been selected. I once again thank our 3 esteemed judges, General Velu Nair, Dr. Raghunath Rao Digumurthy, and Brigadier Dharmesh Soneji. And this entire session and the competition has been coordinated by Dr. Anand Gokarn. Anand Gokarn, as you all know, is professor of medical oncology and hematology at Tata Memorial Hospital. So each of these presentations will have 6 minutes, followed by 2 minutes for questions. And these questions can be from the judges or anybody else. So over to you, Anand, please.
Thank you, Dr. Purvish Parekh, for this wonderful conference and giving me an opportunity to go through these abstracts. And I would like to thank the judges yesterday for selecting the top 6 abstracts to be presented today. So the judges we have today need no introduction at all. All of them are prominent medical oncologists of this country. We have Dr. Raghunath Rao, who is one of the senior most and respected medical oncologists of the country. And he will be there along with Dr. Velu Nair, who had been in the armed forces and now is in Apollo Hospital, Ahmedabad. And he also has been we are very thankful for him for being there for this abstract selection. And we have got Dr. Dharmesh Soneji, who is a senior medical oncologist in Delhi at the Army Research Hospital. So I thank all the 3 judges for being there, and without wasting time, I would like to start with this section. For the first, this first speaker is Dr. Shiva Sri Krishkesana, and she is from Adyar Hospital, and she is going to present her paper on pediatric chronic myeloid leukemia. Shiva Sri, are you there?
Yes, sir. I'm here, sir.
So you can start. Your time starts now.
Yes, sir. Thank you. So pediatric CML is rare and constitutes around 2% of all the leukemias in age less than 15 years. And the management is challenging mainly because of the lifelong treatment of TKIs and the adverse effects associated with it. And it's even more amplified in our setting because of the delayed presentation of the population and the higher rates of non-compliance and amendment. Next slide, please. So this is a study carried out at Cancer Institute from January 2000 to December 2019 of 95 patients who were diagnosed with Ph positive CML of age less than 18 years and treated with imatinib. Next slide, please. The primary objectives being the study of pediatric CML and the response rates to the imatinib. And the secondary objectives, event-free survival, wherein an event is defined as a loss or non-attainment of CHR, CCYR, and MMR at 3, 6, and 12 months respectively, or progression to accelerated phase of blast crisis or death due to any cause. The other being overall survival and the toxicity profile. Next slide, please. So in children weighing less than 40 kg, imatinib was started at 260 to 300 mg per meter square, rounded to the nearest 100 mg dose, and weighing more than 40 kg, it was started flat 400 mg dose. And periodic reassessment was done by clinical examination and the complete hemogram. So periodical cytogenetic and molecular responses were assessed either using FISH or quantitative PCR by RT-PCR method. Next slide, please. Statistical analysis was done by SPSS software, and the descriptive analysis was done for the baseline clinical parameters and treatment details and toxicity profile, and survival was calculated using Kaplan-Meier method. Next slide, please. So of the 95 patients, we've seen that around 23% of them were aged less than 10 years, and around 77% were aged more than 10 years. It's got a male predominance of with 57% of them. And the chronic phase constituted around 88%, followed by accelerated phase and blast crisis in 6% and 5% respectively. Low risk and intermediate risk SOCA score was seen in around 80% of the patients, and high risk was seen in around 15% of the patients. Next slide, please. So responses with the imatinib, CHR was attained in around 96% of the population, and CCYR in 77% and MMR in 55% of the population. Primary imatinib resistance was seen in 3% of the population. Next slide, please. So the responses with imatinib as per the timelines is scheduled in this, and we have seen that the dose modification was required in around 45% of the population, wherein dose de-escalation was done in 4% because of the imatinib intolerance, and dose escalation was done in 40% of the population either because of loss or non-attainment of the response. And around 25% of them has progressed on imatinib, and 12% had lost 2 follow-up of the kinase domain mutations, 12% of which was carried out, and 5 of them had positive, and 3 of them had T315i mutations. Next slide, please. So as per the timelines, 60% of the CHR was attained in 3 months and around 88% by around 18 months. CCYR was attained in around 15%, 35% and 40% respectively at 6 months, 12 months and 18 months. MMR was attained in 5%, 20% and 25% at 6 months, 12 months and 18 months respectively. Next slide, please. So imatinib toxicity, most of the patients are tolerated very well, and the other patients who had, mainly it is the musculoskeletal present with polyarthralgias, muscle cramps and pains in around 70%, followed by dermatological hyperpigmentation 11% and skin rash in 5%, followed by myelosuppression around 9% of the population. Next slide, please. So mainly the acute toxicities were seen were mainly hematological and GI symptoms for the acute initial 2 to 3 months, and chronic, mainly the fluid retention, hypothermia was seen in the late chronic phase. Next slide, please. So the because of the 20 years follow-up duration, we have seen that of the 6 married males, 5 of them had children, and 1 patient had azoospermia. And of the females, 6 of them were married, and 4 had children, and history of abortion was there in 2 patients. Next slide, please. So 4 of them have required second-line TKIs, of which nilotinib was given mainly for the primary TKI resistance or the imatinib intolerance, and dasatinib was given patient who had intolerance for the nilotinib and loss of CCYR. And hematopoietic stem cell transplantation was carried out in 4 patients, the indications being blast crisis in the T315i mutations, of which 2 of them had transplant by mass sibling donor and 1 each from haplo with father and 1 from unrelated donor. Next slide, please. So the overall survival median duration of follow-up was 98 months, and overall 8-year overall survival was seen in around 80%. Next slide, please. And 8-year EFS was seen around 43%. Next slide, please. Of the univariate analysis done for the baseline features and the treatment factors, it was observed that the CCYR at 6 months, 12 months, and MMR at 12 months was associated with better EFS, and chronic phase and CHR at 3 months, 6 months, and CCYR at 12 months was associated with better OS. Next slide, please. On multivariate analysis, it was found that chronic phase was associated with better OS, and CCYR at 12 months was associated with better EFS. Poor compliance was seen around 20% of the population, and of the 95 patients, 64 are alive now, and 12% were lost to follow-up, and 19 had expired because of progressive disease. Next slide, please. So the limitation being retrospective study and availability of BCR ABL only from 2013 in-house, and there was a non-uniformity because of the financial constraints. It was run at different points of time. And non-availability of growth context. Next slide, please. So these are the various studies which is carried out on pediatric CML from India, and this our study being the longest duration and the follow-up. Next slide, please. So the conclusion is that pediatric CML data is comparable to that of other Indian and Western literature, and outcomes are comparable with that of adults, and imatinib is well tolerated in children, and also the necessity of transplant has drastically come down with the introduction of TKIs. Thank you. Next slide, please.
Thank you, Dr. Shivashri. I request the audience, if they have got any questions, they can ask the questions.
So one question is, did you have any challenges in doing the testing in-house, setting up the RQ-PCR in-house?
So it was done in 2013, so I was not aware whether there were any.
Okay. No. General Nair, if you have any questions.
Yeah, Dr. Shivashri, thank you for a very good presentation. And on an important aspect that too in pediatrics, which we have data is sparse. So my question is that if you were to do the study now, it is a retrospective study.
Yes, sir.
What risk stratification, you use SOCAL here, what would you use now if you were to design a study on pediatric population?
Yes, sir. UTOS long-term survival.
UTOS?
Long-term.
Oh, okay. ELTS. Okay. Okay.
Hello, sir. Sir, am I audible?
Yes. I've got your answer. And the 2 other questions I want to ask you is, what are the problems in children which you don't usually find in adults in day-to-day management of these cases? In children, there are certain management issues which comes up, which in adults you take it for granted. And one of the important side effects which you must monitor. You're designing the study now. Forget about the
Mainly the growth monitoring, sir. Growth monitoring has to be done.
Very good. Yeah.
That's
Growth
main
monitoring
important.
and to ensure adherence. That is usually a problem in children because you said 70% were about 10 years now in your patient, in
Yes.
your group.
Yes, sir.
Dr. Harita is asking, is treatment-free remission recommended for pediatric CML?
No, sir. It's not recommended for pediatric cases. Even only there are some trials which are going on, but it is not recommended as of now.
Right. Thank you very much.
Thank you.
Over back to Anand, please.
Yeah, thank you, Dr. Shivashri. Now we go to the second speaker. He's Dr. Rajan Kapoor from the Armed Forces, and he's going to speak on his paper on the risk stratification of chronic myeloid leukemia chronic phase in a real world scenario. Over to you, Dr. Rajan.
Good afternoon, everyone. So throughout this conference, we heard that hemato-oncology is now spoiled with choices of TKI which are available. So there is ever increasing need of a proper risk stratification. So as you know, very limited data from Asian population, there is only one study confirmed which had done an upfront risk stratification in Indian patients. Next slide, please. So why we did this study was we wanted to do a comparative assessment of the known score, the SOCAL, Hasford, and the UTOS in a CML-CP patients on imatinib. We wanted to see what is the rate of fall of BCR-ABL transcripts and whether they were achieving the therapeutic goals. And among other important factors, many patients go on to second generation TKI. Can we predict this with this score? Next slide, please. So we went ahead, we had a large data set of 653 patients from Army Hospital in RNR from 2016 to 18. We diagnosed CML-CP as per the WHO criteria, and all were given generic oral imatinib 400 mg. Next slide, please. So baseline characteristics to calculate the score was done in all, and we at the diagnosis we calculated and did these three scores. I just want to bring out that we had an in-house software which we designed, which was linked with the software of R, and I'm proud to say that this is the basis of software now in Hematology Cancer Consortium, where the major hospitals are using. Next slide, please. So this is the SOCAL, Hasford, and UTOS. As we all can see, the UTOS is the easiest one where we do only screen size and base total count. ELTIS is the latest kid on the block. Same as SOCAL, weightage of age is decreased. It's mainly to detect the mortality associated with CM. Next, please. So coming to the results, the demographic as an Indian patient is a younger patient crowd with 43 years median age, more male predominant, and this is our median follow-up. Next slide, please. So the baseline characteristics, these are the parameters which are required for the SOCAL and Hasford as well as the UTOS. The spleen size being 8 centimeters is larger than what we see in Western. Next slide, please. Now coming to the graphs. So here we see what is the distribution of patients in percentage, which is depicted in these bar plots according to the risk score. As you can clearly see, SOCAL low and intermediate and Hasford low and intermediate has almost the same distribution. There's a significant difference in the high score, almost 20% patients falling in the high score. But when we see the graphs of UTOS, there's a distinct difference between the high and the UTOS low. Next slide, please. Now, this is the graph, the bar plots. On the y-axis is the percentage of the goals which we want to achieve. The first goal is less than 10% at 3 months. At 1 year, less than 1%. This is equivalent to CCR and MMR at 3 months. Now, I want you to focus at the MMR. If you see this dashed line, this is the difference between MMR and SOCAL low and high. Now, for the purpose of this graph, we have plugged low and intermediate together. This is in the Hasford, but we clearly see the UTOS scores over with a significant p-value where only 24% of UTOS high achieved MMR at 18 months. Next slide, please. Now, this is the graph which is showing on the y-axis. Again, we have the BCR, median BCR-ABL values transcript, and these are the months 3, 6 going up to 36. Now, if you see at 6 months of age, the red line for all the scores is the high risk group, and the green one is the low risk. Now, we can clearly see the difference, the discriminant function of UTOS high. There's a clear difference between the high and the low risk with a p-value of very significant less than 0.002. Next, please. Now, this we have put it in one table. If you see, this is the SOCAL, Hasford, and UTOS, low, intermediate, and low, high in UTOS. If you see our first target less than 1% at 1 year, SOCAL does predict, but UTOS is a clear winner with a very significant p-score. And when we see the MMR, the Hasford unfortunately does not predict between, if we combine the low and high, there is no predictability of Hasford, but UTOS again is better. And if we see the median months which we take to get to the CCR, the hazard ratio is clearly 0.4 in case of UTOS, and the p-value is highly significant. Next slide, please. Same thing which is seen in MMR. Again, UTOS goes over if you see the hazard ratio and the p-value is highly significant. So we can safely say the UTOS is the best of these scores when we want to predict the MMR and other therapeutic goals. Next slide, please. Now, this is the interesting part which we actually wanted to do. So what are the patients who shift to second generation TKI? And if we plot them according to the risk score, you see that obviously all the scores like SOCAL high, HASFORD high, they do predict that most of them would go on for second generation TKI. But if you see the UTOS high, almost half of them, I mean 45% of the patients are likely to go and require second generation TKI within 1.5 years. So this is a very important thing which has come out of our study. Next slide, please. So if we see the Indian study, which is the score is better, this is a study from AIMS which showed that the SOCAL is better than the other scores. The Korean study says that UTOS is better. UTOS actually was made on imatinib, so was the Turkish study. Next slide, please. So we takeaways from our study, novelty of our study, to our mind, this is the first study in India which has said we can predict by using UTOS score which are the patients likely to require second generation TKI. We can predict the depth of the response, and the high risk group has an unfavorable outcomes in achieving therapeutic milestones. Next slide, please. So high risk group discriminated by UTOS may benefit from upfront second gen TKI, especially with the generic dasatinib coming and the other compounds also likely to be available. And very important thing is there is no difference with the low and intermediate risk groups as far as SOCAL and HASFORD is concerned. So I think they should be clubbed together. So we have to have only two groups, high and low risk. Thank you.
Rajan, as you mentioned, you work in challenging circumstances for unique considerations. So one of them was you mentioned that having the test routinely done outside when patient has to pay for it is difficult. But do you have a mechanism of how you assess your patients?
Yes, sir. Like assessment, one is that the clinical assessment, we do the prognostic score, but we have, your question is about the BCR-ABL monitoring, sir, if I correctly get it?
How can you assess them when they can't afford it?
No, they can afford it. I did not say they cannot afford. They claim it back, but they have to pocket initially, and that was in consideration with the TFR, which I was talking, because every month giving and claiming it back at all centers. Now, major centers have in-house BCR-ABLs. I'm saying since the patient crowd moves a lot, they go to a smaller setup also. So that was the consideration. Otherwise, affording is not a major issue, at least in our setting.
Right.
Thank you for this novel, work, and I really think that software which you developed is so good because it's obviously going to benefit a lot more centers and a lot more people. Is the biggest spin-off of this whole thing. Have you started applying this prognostication in practice?
Yes, sir. So we are doing prognostic score, but as we are doing this ELTS, we have not been doing, but we are doing retrospective application of the ELTS. Now, the major thing about the ELTS is that the group of low and intermediate, actually they combine and that proportion increases and the high risk group goes down. Now, this is a very important thing which you actually had brought out yesterday also, that more and more with the availability of a generic second generation, we have to select out patients who should be given upfront second gen TKI. So if we have a lower proportion of a patient population where we can give a second generation TKI, that definitely would be good. So next part of our study would be to apply this ELTS score and see whether we can have a better discriminant of a patients who require upfront second generation TKIs.
Since we have a large network of CML patients in the armed forces, and I just want to clarify Dr. Purvish's point also, that all the patients who actually do any test, they get reimbursed. He has to spend out of the pocket in the beginning, but he gets reimbursed. But the point I am driving home, Colonel Rajan, here is inappropriate risk classification jeopardizes optimal treatment selection, that we know. And the way to go is to actually risk stratify them and to do it and to actually disseminate this. It's not being done. So I think it's a great idea and we must actually disseminate this information more because it should be practiced. Thank you.
Thank you, Dr. Rajan. We move to the next speaker. The next speaker is Dr. Aditya Ilhans, and he is going to talk about facilitating treatment of CML in Madhya Pradesh.
Good afternoon, everyone. I'm Dr. Aditya Lens from the Department of Medical Oncology, Sri Aurobindo Institute of Medical Sciences, Indore. And my topic for today is facilitating the treatment of CML in the heartland of Madhya Pradesh. As you all know, chronic myeloid leukemia is now an increasingly curable disease, and survival now parallels that of healthy individuals. The objectives in a community cancer center in the rural healthcare area such as ours is to ensure proper access, delivery of treatment, monitoring, and regular follow-up. Next slide, please. I hereby present retrospective data for patients with chronic myeloid leukemia registered in our OPD between August of 2013 to March of 2020. The clinical, hematological, and molecular data was collected for all patients, and follow-up status and CBC were conveyed over WhatsApp and telephone. Next slide, please. As ours is an academic cancer center located in the suburban Indore and caters to the medical needs of around 17 districts of Western Madhya Pradesh, majority of them having a rural population. And the median distance from our treatment center for the patients of CML was around 77 kilometers, the average, the range being 15 to 400 kilometers. Next slide, please. We evaluated the medical records of 63 patients, the median age at presentation being 38 years, with an equal male is to female ratio and a rural is to urban ratio of 5:1 for the study population. The annual family income being 79,000 rupees per year, and around 10 patients abandoned treatment, and all of them did so between the year 2013 to 2015. Next slide, please. 68% patients had an initial total leukocyte count of 1 to 3 lakh, and 17% had a TLC count greater than 3 lakh per cubic millimeter. And 43 out of the 53 patients that were treated in our center, they were in the chronic phase at presentation, while 7 of them were in the blast phase. Next slide. Only 39% patients underwent FISH at baseline. And when we see the 2-3 year epochs, that is from 2013 to 2017 and 2018 to 2020, we can observe a significantly higher number of patients underwent FISH between 2018 to 20. This partly reflects on the availability of financial aids during this period from the various NGOs. And around 87% patients were managed with hydroxyurea and hydration alone at presentation, while rest also received either chemotherapy or leukapheresis. Next slide. On the observing the frequency of follow-up, we see that there was a trend towards improved 3-monthly follow-up, and this in part reflects the improved patient counseling and care, along with better access to financial aids. Of the 10 patients who chose to abandon treatment at our center, a majority of them did so due to paucity of finances and difficulty in the access to the healthcare center. Next slide, please. Of 53 patients who did continue under our care, 51 patients were started on upfront imatinib, while 2 of them were started on nilotinib, both of them being supported by ESIC. Next slide, please. Complete hematological response was achieved in 46 patients at 3 months, 5 patients at 6 months, and 4 patients at 12 months. And only 19 patients were evaluable for the major molecular response, the rest not being so due to financial constraints. Out of 19 patients, 7 achieved a major molecular response at 6 months, 10 of them achieved it at 12 months, and 2 never achieved a major molecular response. Next slide, please. When we closely observe the treatment finances for our patients, we see that approximately 50% receive benefits from the various Government of India run schemes such as the Ayushman Bharat, ESIC, and the Chief Minister Relief Fund. 25% patients received assistance in some form or the other from the various NGOs such as the GPAP program, the Teenage and Young Adult Cancer Foundation, etc. And 25% patients were self-dependent for their treatment. Next slide, please. So in conclusion, achieving optimal results in CML needs societal and organizational efforts in rural healthcare setting, for a better access, continuation, and monitoring of treatment. As an academic cancer center working in resource-poor setting, we have managed to achieve modest results, and incremental improvements in the 2-3 year epochs has been seen. Access to molecular tests will improve with government support for BCR ABL testing if provided. And lastly, second generation tyrosine kinase inhibitor should be included in the new Ayushman packages if allowed. Thank you, sir.
Thank you, Dr. Aditya. I would like, if anybody has questions, just you can ask those, or you can type those in the chat box as well.
So Aditya, being in a rural setting, what are the challenges that you face in ensuring proper compliance with both treatment and diagnosis? And what do you do to ensure that you help the patient?
Okay, sir. So basically, the challenges that I felt that we encountered during our quest for better treatment for CML are that firstly, that within the rural population, there is always a difficulty of access to the healthcare center. Patients might be coming on from very far-flung areas of Madhya Pradesh and even the northern parts of Maharashtra. And for such patients, a regular follow-up and treatment compliance remains a difficult task. So as I stated in my presentation, sir, we have tried to maintain telephonic contact at least monthly for all our patients. And apart from that, treatment finances remain a very big challenge for us, sir.
Dr. Aditya, you showed as your average yearly earning is less than 80,000 in the family.
So,
So as I understand, most of the states, I don't think MP is an exception. If your income is actually less than about 2 to 2.5 lakhs, you get support from the CM's fund, which is quite across the board.
Yes, sir.
Number two, 10% of your people dropped out. So have you got any mechanism in-house to facilitate these support mechanisms? For example, the people who are ill affording, who can actually tap on these resources?
Yes, sir. We have different mechanisms to deal with such problems that arise. So first of all, that Chief Minister Fund was always a very limited option for us because the amount that is usually coming for Chief Minister Relief Fund for various patients is basically between 50,000 to 1 lakh, and that is actually exhausted pretty quickly. Seeing, taking into account that patients are coming, then actually they have to get admitted for the CM fund to be activated at the hospital, and that actually raises the bill by quite a bit. Say around, if they are getting a imatinib tablet for 2,000 rupees, and then probably the admission charges for that would be 2,000. So that would be a big problem, and the resources would get exhausted quicker. Apart from that, sir, we do have different mechanisms, like we support our patients through the Teenage and Young Adult Cancer Foundation as well, especially the patients of us who are between 15 to 30 years of age. And apart from that, we as a department have actually started a initiative whereby we provide free residence and accommodation to our patients at a nearby facility, that patients can actually have to pay a very bare minimum amount to be there, and they're provided with food and lodging, everything.
Thank you, Aditya.
Sir.
Thank you.
So I thank all the three speakers for the first session, and the second session, the next three speakers would be in the second half at 4 o'clock. So I hope all of you join us at that time also. I hand over it back to the organizer for this continuation of this conference.
Thank you so much, sir. We'll now move on to the debate. Our first debater is Dr. Uday Y, hematologist from the Armed Forces. Over to you, sir.
Hello.
Yes, sir, we can hear you.
Yeah. Can.
Oh, sorry, sir. Sorry, sir, you'll have to unmute your mic again.
Firstly, I would like to thank Dr. Purvesh Parikh and all the organizers for giving me this opportunity to talk. In fact, I had a severe turmoil over the last few days on the family front, but just because Dr. Purvesh has ordered me to definitely deliver this lecture, so I couldn't say no to him. So let me try to justify whatever is possible. Now, as soon as the topic was given of supporting Ponatinib in CML patients with T315i, I thought that as if I have to make Mahagathbandhan win in Bihar or make Donald Trump win in US. So, but after going through after researching the topic, I thought then it's not so difficult. So coming back to the topic for the day, that is Ponatinib in CML patients with even T315i mutation. So basically in these mutation patients, we have got three options: Ponatinib, LOHSCT, or Omacetaxin. Now, Omacetaxin is not yet available in the country, and also the data is very short. So we'll primarily discuss about Ponatinib and Allogeneic transplant in patients with T315i and who would be the winner. Let's see at the end of the debate. Firstly, coming to the outcomes of Ponatinib in T315i mutation. Now, if you look at the efficacy, so around 66% of these patients achieve complete cytogenetic remission and 70% patients achieve major cytogenetic remissions, and 85% of these patients remain in major cytogenetic remission at 5 years. So if you look at the 5-year results, so the results are pretty impressive in that in a patient who is already has received a previous TKI, developed T315i, and still has around 58% of MMR at the end of 5 years is quite impressive. But as you all understand, just looking at only one drug, and that if you look at the previous numbers, only 64 patients, is not a very good idea. And this paper, these results are from 2013 paper. In a 2018 paper, they then analyzed 267 patients, which was finally published in 2020. And they have shown that similar results are in both 1 year as well as 5-year response. Now, if you look at this 2020 February paper again, they have shown that those patients who are in CP with T315i, the Ponatinib has got a better survival, overall survival, when compared to those patients who are in accelerated phase or blast phase of CML. So, Ponatinib really helps in those patients who are in CP when compared to in the advanced phases. Now, if we compare the remissions with other TKIs, so this is a forest plot wherein Bosutinib from Bela trial, Dasatinib from Decision, Nilotinib from Ernest ND, and Ponatinib from the PACE trial have been compared in a forest plot. You would see that when compared to Imatinib, all of these, including Ponatinib, do well. And in fact, Ponatinib do slightly better when compared to other second generation TKIs. And also if we compare the outcomes between the various trials, inter-trial comparison as we call this, in comparison to Imatinib. So most of the drugs except Bosutinib have been more or less equivalent to that of Ponatinib. So this is just to emphasize that Ponatinib is a good second generation TKI. So to summarize the first part of it, the substantial remissions with Ponatinib in patients with T315i. Now, so let's also look at allogeneic transplant in T315i mutations. So there are two papers which I'm going to show you. One is a 2011 paper which shows that the survival in those patients with T315i is very good in those patients with CP, whereas the survival keeps deteriorating if we look at the advanced phases or in pH positive ALLs with T315i. Now, if we look at the remission at the time of transplant, even in those patients, both AP as well as CP do well, whereas those patients who are still in blast phases, wherein we are doing a salvage transplant, or those patients with pH positive ALL, so the transplant has got a survival something closer to around 60 to 65% at 4 years in these patients. Now, if we look at another paper which was published in 2016 of transplant in CML, the data is no different, though the population is very small. It's only in around 20-22 patients. So the survival ranges for CP up to 80% to blast crisis, wherein the survival is only up to 20%. So allogenic transplant benefit mostly patients in CML CP with T315i mutations and has dismal outcomes in accelerated phase or blast crisis T315i mutation. Now, if we also look at the Indian data, so I'm first showing you the CMC Velo data. So it shows that previously 1988 to 1996, the survival was somewhere around 25%. But even if you look at 1996 to 99, that is before the advent of the TKIs, the survival was somewhere around 70% in these patients with CML. Now, AIMS data, similar. Out of 14 patients, only 8 are surviving, 6 have died. So the survival again comes to, at 5-year survival, comes to around 60 to 70%. Now, because it's a Dr. Advani's symposia, so I should include TMH data. So in TMH data, wherein 17% of these patients were T315i mutation, the overall survival at 5 years was 50% and the progression-free survival was 57%. Now the updates of this further, if we look as far as the remission status, 5-year survival was extremely poor in those patients with blast crisis or accelerated phase. So to summarize, the Indian data also corroborates with the international data that in patients with T315i in accelerated phase or blast phase, the results are really dismal, whereas in CP they are comparable to the overall outcomes that we have spoken about with Ponatinib. Now to compare the outcomes of Ponatinib with transplant head to head. So there is only one trial which has compared head to head between the two, and it clearly shows that Ponatinib does much better, significantly better when compared to transplant at 2 years. So these are the curves. On the top you could see the Ponatinib and at the bottom you see the allogeneic transplant. Now if you look at AP, BC and PH positive ALL, so as with any other transplant or as with isolated Ponatinib, the results are no different and both of them do bad or do poorly. Either you use Ponatinib or you use transplant for a 2-year survival. So Ponatinib is better than allogenic transplant in patients with CML-CP with T315i. Now, if Ponatinib is also not doing well and transplant is not doing well in patient with accelerated phase or blast crisis, can we combine both of them? So initially there were case reports which suggested that yes, there will be a benefit. Then there was a retrospective study of 10 patients which was published in 2019. And finally in 2020, there was a study which clearly shows that by using either Ponatinib or CAR T-cell as a bridge to allogenic transplant can improve outcomes. And finally, this year, at the middle of this year, we have a beautiful paper which shows that in patients with CP, adding transplant to Ponatinib has no benefit, whereas in those patients with accelerated phase or blast phase, those patients who were transplanted along with Ponatinib had a significantly better survival when compared to these patients without transplant. So from this graph, you could clearly make out that in CP patients, just give Ponatinib, and those patients with accelerated phase or blast phase, combine both of them or use Ponatinib as a bridge to transplant. So this would be the summary of it. Ponatinib with allogenic transplant in AP or BC can have a significant benefit. Now, all of us, we are all prejudiced towards Ponatinib for the side effects, particularly vascular events, particularly because the FDA had withdrawn the drugs for around 3 to 4 years in between after the Ponatinib was launched. So if we look at this, this is a side effect profile. Now, this is a beautiful graph which shows that out of all the side effects, the commonest is thrombocytopenia, then is abdominal pain, then is anemia, lipase, rash, and neutropenia. And if you look at the vascular events, those in red, extremely small when compared to other side effects. Also, if you keep decreasing the dose of Ponatinib, so cardiac side effects aren't huge with Ponatinib. Now, if I would like to compare the vascular events with all other TKIs, you could clearly make out that the patients with Ponatinib are no worse when compared to Bosutinib, Dasatinib, or Nilotinib as far as the vascular occlusive event is concerned when we do an inter-trial comparison. Now, can we mitigate the side effects? Yes, I'll quickly go through this. So we have a ESC risk scoring, do that scoring, do a pre-Ponatinib evaluation as we do in Nilotinib as well. And thereafter, try to control the cardiac adverse factors, that is the blood pressure and the triglycerides and the sugar, and they would be much better. Now, this is a beautiful graph to show that pre-2014, they never used to do a cardiac monitoring well. So the patient had these large dots will show that huge cardiac events. Whereas post-2014, when people started evaluating these patients better and started referring them to a separate specialty known as cardio-oncology, the number of cardiac events have significantly come down from 30% to 19.5%. Now, also, people have a fear that if we keep giving Ponatinib in a cumulative prolonged duration, there will be an increase in the overall cumulative adverse event ratio, but no, not exactly. If you see that exposure adjusted arterial occlusive events, it's hardly 6%, 5%. So, and if these patients were monitored well, it's just 2% or 1.8%. And I would feel that the same amount of percentage would also be there in NSTND with Nilotinib. So, Now, if I want to compare the side effects of Ponatinib versus transplant, if I am looking at a vascular event of 2% to 19%, the TRM with transplant across world is 20 to 30%. And if we see it in India, it's 50%. And if I look at 5-year MMR of 58%, the 5-year survival of transplant is only 20% in some sets and can range up to 80% if the patient is in CP. So there is no huge difference in the morbidity and mortality, though people have not compared it statistically in a direct trial in a randomized controlled fashion, but by taking the figures from the previous data, they are comparable. So side effect profile is not high if monitored well. So to summarize my debate, I would say that finally Ponatinib is an inevitable drug in patients of CML with T315i with or without transplant. So in patients with CP, just we can go ahead with Ponatinib. Whereas in patients with accelerated or blast phase, we can add transplant on the top of Ponatinib or use Ponatinib as a bridging therapy. So to conclude, Ponatinib is a drug which is inevitably needs to be prescribed in patients with T315I mutation. Thank you.
Thank you so much, sir. We'll move on to our next debater, Dr. Puneet Jain, hemato-oncologist from Navi Mumbai. Over to you, sir.
Puneet, you can
Am I
unmute. You are unmuted. Go ahead. We can hear you.
Hello.
Yes, sir, you're audible.
Yes.
So can you hear me?
Good afternoon, everyone. A nice presentation by Dr. Uday, but I'm going to put forward my point of view. So I'm going to talk against Ponatinib on patients with CML and T315I mutation. Are the slides moving? Yeah. So I have no financial disclosures. As we know, kinase domain mutations kind of offer a poor prognosis in patients with TKI resistance. T315I mutations constitute around 20% of the patients, and among all, quite a lot of mutations, T315I mutations do poorly in these patients. There is no doubt about the in vitro sensitivity of T315I mutation to Ponatinib. They are very sensitive, and in fact, even the guidelines, some of the guidelines do recommend use of Ponatinib upfront. Also, as Dr. Uday has shown, the use of a lower dose and taking cardio-oncology unit into consideration, the doses of Ponatinib have been reduced from 45 to 30 and 15 milligrams. But I have some evidence against Ponatinib as upfront therapy. Now, obviously, this is the most talked about thing. It causes a high financial toxicity. 15 milligrams of Iclusig probably is costing around 4 lakhs per month. And per year, it is costing around 47 lakhs. And if you look at the 45 milligrams dosing, it constitutes around 78 lakhs per year. These are recurring costs every year for the rest of your life. So if the cardiac toxicity doesn't kill you, probably the financial toxicity will really cause a lot of stress. Adverse effect profile, yes, pancreatitis, hypertension, dyspnea, cardiac failure, hematological events, thrombocytopenia, neutropenia have been discussed. But what was important was there was a high rate of discontinuation of patients who were on Ponatinib. And yes, there was a talk whether this study was from the PACE trial, and there was a lot of patients who had been treated with TKIs before when they had been put on Ponatinib. Yes, the new onset non-cardiogenic adverse events had increased in Ponatinib on dose-dependent basis. Also, the new onset cardiac events were fewer, but they were still there. Arrhythmias and causes of sudden death were there even with lower doses of Ponatinib. But this was a trial which was mentioned, and my friend did not mention it. This was the EPIC trial wherein Ponatinib was compared to Imatinib upfront, 45 milligrams to 400 milligrams. And as you can see, patients with more than 18 years of age were involved, and this trial had to be terminated at the end of 1 year because of serious side effects that occurred in 3 or more patients. And as you can see, Ponatinib had shown cardiovascular, cerebrovascular, and peripheral vascular diseases. This slide was rightly shown by Dr. Uday. But let's talk about the tolerability of Ponatinib in Indian patients, because we tend to follow the West and we tend to copy them. But what about the tolerability of Ponatinib in our patients? So there were some 14 patients who had a background T315I mutation. And this was data, retrospective data. Max Foundation had supported it, and 23 patients across 3 centers in India who had used this drug. There was, as mentioned, 14 patients with this mutation. Median time was 10 months, and the most common side effect was thrombocytopenia, followed by skin rash, and grade 3 to 4 cytopenias were seen in 9 patients. And in spite of the lower dose, cardiac events were still seen in 4 patients. In fact, a lot of patients had a lot of discontinuation. Ponatinib had to be stopped in few, and there were temporary discontinuation, even though in some patients in whom Ponatinib was continued, there was significant thrombocytopenia. So if you look at the life after Ponatinib failure, those patients who have had Ponatinib toxicity and discontinuation of Ponatinib had a poor long-term survival. If you see, out of total 36, 24 had actually succumbed to the disease. So also in those patients whom Ponatinib had been used, the degree of major molecule response was good. There was no doubt about it. In those patients in accelerated phase, the major molecule response was seen in 22 months. Cytogenetic response was 33 months. Even in blast phase, the cytogenetic response was only 21 months. But there was, or if you look at the long-term survivals, with only Ponatinib CML patients, 1 year survival was only 29%. What about additional mutation with T315I mutation? If you have T315I plus an additional mutation, the cytogenetic response or the molecular response is poorer in patients with only T315I mutation. So that aspect has to be looked at, as seen in these graphs, showing a poor progression-free survival also. So what is evidence for transplant upfront? This was the paper by Nicolini. There are 2 major papers. This is again a retrospective studies. As you can see, 24 months follow-up. Those in CP had almost 60% survival. Accelerated phase had 67% survival. And obviously blast phase had only 30% survival. TRM at 3 months and 12 months was 9 and 18%. Acute GVHD was seen in 71% in grade 1 and 2 and 18% in grade 3 and 4. Chronic GVHD was almost seen in 48%. And those patients who had a chronic GVHD had a better overall survival. The type of conditioning, the interval between the mutation and the transplant, and the source of the cells had no influence on the overall survival. So this was again the paper by which Dr. Uday also showed, that there were 22 patients who had this mutation and who had undergone a haplo transplant. The intensity of the conditioning regimen was definitely intensive, because they had added 2 grams of cytarabine in addition to the standard regimen that they were used. But if you see, the leukemia-free survival with CP was 80% at the end of 2 years, 72% in AP, and almost nil in nil in patients with blast phase. So the TRM rate was around 18% with a median follow-up of 17% post-transplant. So at end, there were 13 patients in complete molecular response and 1 had an extramedullary relapse. So even in those patients who have had a transplant and relapse, there is data for use of TKI with or without DLI, and who have shown that even if patients undergo a relapse, they can be salvaged with one of the measures that is shown in the graph. So I would conclude saying that CML in indications of a transplant, I would still consider T315I mutation upfront as an allogenic transplant, considering this paper by Nicolini that yes, the patients with accelerated phase had almost similar survival with Ponatinib, but would you offer transplant as a one final cure in these patients, considering the adverse risk ratio and the financial toxicity, or would you offer only Ponatinib? That is the question that we need to answer. Thank you.
Thank you so much, sir. We'll now move on to our next debate. Our first debater for the debate is Dr. Rahul Bhargav, hemato-oncologist from Gurugram. Over to you, sir. Rahul, sir, you'll have to unmute your mic.
Okay, so the topic is the TFR. Is it for everybody, or which way we want to move ahead? So we have gone through a sea of generation changes in CML, from allogeneic transplant to smaller molecules like imatinib, moving to dasatinib, nilotinib, and probably this decade is more towards TFR. So might not be for all, but yes, for sure, it is for the few which needs to be chosen. And those are the chosen ones. Why? If I have to just finish it off in 2 lines, then I can say it helps to reduce the toxicity. It gives you a chance to have a better survival, quality of life, which still in India is a remote parameter in cancer when it comes to cancer. And of course, the financial toxicity, it might be a generic dasatinib or nilotinib, but the financial toxicity still remains a major problem. So the goal of CML therapy is moving the disease control from best overall survival has moved on to operational cure. And this is where we stand today. And this is where the median survival for imatinib stood when this drug came by. And we are talking about normal survival up to 70 years in this today's era. The future focuses on CML studies like maximizing TFI eligibility from the start, the deep molecular responses, and stop where we need to stop. And in previous 1 hour, where Rajan has spoken about Utah score to choose the best therapy, moving on to the second line therapy. And Dr. Purvesh has actually managed to sequence the talks in such a manner which helps you to actually see through the CML journey, moving from choosing a drug to finishing and stopping the drug. And this is where we stand at today's experience with TFR studies is ever growing, because everybody wants to enter into where the disease can be cured and the people can be off therapy. So imatinib, nilotinib, and dasatinib, because whatever we say, the chronic toxicities of these medications stands tall. The dasatinib, right-sided heart failure, pleural effusion, even coming after 2 years. With nilotinib, pancreatitis, people developing diabetes mellitus is no small barriers. So how can we improve these percentages? More powerful TKAs have started coming in. As we know, the MR 4.5 is ever increasing, and that's where the MR 4.5 from Dacian trial at 42% remained. This was the gateway. MR 4.0 was the gateway for achieving the TFR, the ultimate goal. And this is how these things at this present moment of time spans out, is associated with improved survival versus CCYR, because people still keeps on progressing to blast crisis. And as Puneet and Uday has shown, that no other medications actually helps you in blast crisis once you progress that path. And we know those people from various trials from Madhya Pradesh and other places, people who tends to progress to blast crisis, the only thing which remains for them is death. So in India, the first chance is the best chance, and all these Utah scores or Hasport scores can actually help you to guide to choose a better TKI upfront. And achieving deeper molecular response is the first step for treatment-free remission, and this is where it remains. The durability and impact of quality of life. So NS-STOP 192 weeks result shows that durability and impact on quality of life of treatment-free remission following second-line nilotinib in patient with chronic myeloid leukemia. And it shows beautifully that what you need to see is here, in NS-STOP trial, TFR 48 weeks after stopping treatment was 58%. The analysis of rates of adverse effects that may have a negative impact on patients' quality of life was very well documented. So quality of life was achieved in 58% of people who could achieve TFR by virtue of achieving MR 4.5, which was at the initial was started by choosing the right TKI. So where you start your journey in CML actually bears the fruit at fifth year or 6th year, and that's where we are landing from. And then the debate is about whether people require TFR. The answer to that is yes. In ever achieving country where the compliance is a major policy, major problem in this country, yes, we need TFR. This is the NS-STOP study trial where the nilotinib was chosen and progressed ahead. And this is how the people achieved. And see, 46% achieved MR 4.5, and the estimated TFS at 3.7 years was 50.3. So if we can achieve this in next 5 years, so today we start a CML patient in chronic phase, and by 2025, if we can achieve a TFR, it will be a significant gains in these people. And the treatment-free survival is ever increasing at 48 weeks, 96 weeks, and so on and so forth. So this is where we are heading for. And what determines at 5th year begins from the day one when how you choose it. And this is how treatment-free survival is increasing, ever increasing. And the cumulative rates regained from nilotinib reinitiation. Many people will say, once you have achieved a TFR and people too tends to relapse, yes, out of 58%, rest of 42% people are going to relapse. Yes, those people can be reinitiated and can be achieved the same remission rates over a period of time. So BCR over time in reinitiation phases can be achieved in a similar manner. So there's no adverse effect. So what is harm in trying TFR when you have achieved the desired criteria for remaining MR 4.5 for 3 years and then progressing about better compliance, better outcomes, better quality of life, saving a lot of money. And this is the stable results has been taken care of in the various studies as you have seen. Conclusion was that second-line nilotinib together with the result from earnest CMR suggests that more patients may become eligible for TFR and achieve successful TFR with the switch to nilotinib versus remaining on imatinib. And side effects are really thing. So moving toward treatment-free remission into mainstream clinical practice in CML, these are the inclusion criteria which has been put forward. Inclusion criteria: so-called score, diagnosis not high, BCR-able transcript, CML past history, response to first-line TKI therapy, duration of TKI therapy, depth of molecular response, duration of molecular response monitored in a standard laboratory for more than 2 years. And this is where we can, if we follow this thoroughly, we can actually have 40-50% people achieving TFR. Deep molecular must be sustained for 1 to 2 years, and that's where the good laboratory comes in, which we have now. So challenging the stringent molecular monitoring has to be put forth. People have to be followed up once a month for 12 months before they can be done at 3 months and 6 months. And these papers are all there. So important issues is, of course, the important issues for monitoring patients who have ceased therapy is 2 monthly BCR able for 6 months, then 3 monthly for between 6 to 12 months, and 3 monthly indefinitely till the time we see these patients. Important issue is the TKI cessation and the planned monitoring. Monitoring is very important. The final question is, which barrier do we still need to overcome to introduce TFR in common practice? Probably is the mental barrier in the minds of the Indian physician, which needs to be done. Proper communication to the patient needs to be done, and proper molecular monitoring needs to be done, which will ultimately leads to better quality of life, because we have to start looking at the quality of life in Indian patients as well. And second, the major important thing is the financial toxicity is going to go away. So we all should be thinking the moment we have a CML-CP patient, now it should be not high risk or low risk. It should be seen as patient willing for a TFR or patient not willing for a TFR upfront. And that's how we are going to have a better future for these CML patients, starting a journey of 3 decades from transplants to smaller molecules to probably a functional cure in these subsets. Thank you.
Thank you so much, sir. I now request our next debater, Dr. Vivek Radhakrishnan, hemato-oncologist from Kochi, to please go ahead. Over to you, sir. Vivek, sir, can you hear me?
Yeah. Can you hear me?
Yes, sir, we can hear you.
Can you hear me? Hello?
Yes, sir, we can hear you. Vivek, go ahead.
Thank you. At the outset, thank you for giving me this opportunity to be a part of Dr. Advani's oncology series. He's always been a great role model for many medical oncologists in India. My topic today is functional cure is a reality in CML today, and to oppose the motion. Now, Rahul made a great case, and I truly like his talks because he presents it so well. But he's actually made it a little easy for me by doing 2 things. One, he has given multiple caveats in his presentation. And second, he has conveniently tweaked the topic by saying TFR and not saying functional cure. The first question I have to answer is, can TKIs really cure CML? Now, we know clearly and quite legibly today that BCR-ABL translocation may possibly be responsible for the CML phenotype and genomic instability, but we know for sure that it is not the sole initiating event in CML, which means that it drives the CML phenotype, but may not be critical for the CML leukemic stem cells to survive, which means that there are independent mechanisms of tyrosine, independent of tyrosine kinase for a CML to survive. So the answer is no, TKIs cannot cure all the CMLs that we see in practice. Now, cure, functional cure, operational cure, TFR, have we defined them well or have we got them right? In oncology, we know for sure that there is no clear definition of cure. Functional cure was introduced by late Professor John Goldman, who said that persistence long-term of quiescent non-mutated leukemic stem cells despite imatinib treatment might be consistent with freedom from relapse to chronic or advanced phase disease, provided that they remain vulnerable to TKI when they are recruited into cycle. Tim Hughes modified it in 2016 and said durable freedom from disease progression and disease-related symptoms and signs. And then they introduced this new endpoint called TFR, where there is maintenance of stable low levels of minimal residual disease or undetectable MRD without the need for ongoing treatment. So we don't have a definition for cure. It is variable. Are all CMS the same? Are all patients having the same risk? Obviously, no. What is the disease risk in CML? Which score do we follow? Do we follow the so-called score? Do we follow the Utah score? All TFR studies, most of them have conveniently excused themselves of the high-risk CMLs. Have they taken clonal abnormalities into the question? Have they taken the poor prognostic CML abnormalities? No. So the disease risk is a bias that most TFR studies have. Which age do you take? Most patients who are young are the ones who may prefer for TFR. But are you going, as a clinician, are you going to be influenced by age or dictated by it? Which TKI will take you to TFR? Today, the data from predominant data in TFR is from imatinib. It's only now that we have some more data coming from dasatinib and nilotinib. It needs maturity of data to say that we are going to use these new generation TKIs for TFR. Degree of depth of response. 50 articles are there today at TFR on TFR. Not 50 defined depth of response by the same yardstick. Again, is it the duration of deep molecular response or the duration of TKI that needs to be taken? There is no clarity. Will velocity of response determine the choice of patient to be taken for TFR and operational cure? We need to know. We still don't have answers to these questions. Which criteria do you want? Rahul mentioned about NCCN, but is it NCCN alone the guideline? There are ELN, there are ESMO, there are Hughes. Hughes guidelines were also mentioned by Rahul. But each guideline, if you see, the nuances are different. The molecular testing pattern is different. What is the level? What is the duration of TKI therapy? Velocity? All these need to be understood better. And we need to say that this is the criteria to which we'll apply TFR. Again, does all TFR, does one size fit all? If you take all CML patients, just about 50% are eligible for attempting TFR. Of the 50% who are eligible for attempt of TFR, only 50% attempt the TFR. Among 50% who attempt the TFR, it is just about 50% of them, essentially just about 20 to 25% are able to maintain molecular response of treatment. So who are we addressing? Are we going to forget that 75% don't need functional cure? Only 25% need them. QOL aspect was something Rahul spoke about. The argument is CML receiving TKIs still do not have quality of life equal to that of general population. But will QOL in a person who is actually not cured ever be equal to general population? Now, though TKI related symptom is what is mentioned, no significant improvement in physical or mental health has happened in any of the TKI discontinuation trials. TKI withdrawal syndrome, a new entity, may actually abrogate some of the benefits of discontinuing therapy. Just because patients are good candidates and meet criteria to attempt TFR does not mean that they are actually willing to discontinue. Anxiety generated by fluctuating BCR ABL levels. Who is going to address that? During follow-up, that's a problem. What is the psychological impact of patients? 50% of them who fail. How are you going to measure that? Is it truly economical? India. An imatinib cost that's available free in a lot of government centers. The cheapest brands cost almost 10,000 to 12,000 a year. the innovator brand about 80,000 a year. TFR testing, if you take, an average TFR testing costs about 5,000 or 6,000 rupees per test. Now, if you apply the NCCN approach, it takes you to 66,000 per year. Now, that's something that we have to actually think in a country like India. Patients, again, need to be willing to commit to the monitoring schedules recommended by physicians. It is globally known that just about 50% of the patients adhere to this monitoring schedule while on treatment. As we close, I would just emphasize that apart from transplant, which is the only treatment which is known to be curative, functional cure or TFR is not yet an outcome that applies to everyone, and it is not a standard of care. With due respects to late Professor John Goldman, using the term functional or operational cure is actually a spin born out of desperation of durable disease persistence, actually, albeit at MRD levels, in the TKI era of CML without a transplant. So let us not celebrate premature victories. Let us instead focus on better treatments, getting better drugs or better treatment systems on something that cures truly and really in this eminently controllable disease. With that, I close. Thank you.
Thank you so much, sir. We'll now move on to the finals of the oral abstract competition. Can I request Dr. Parekh to please introduce our convener? Over to you, sir.
Right. Once more, it is my proud privilege to introduce Dr. Anand Broker, who is faculty and professor at Tata Memorial Hospital, and who has taken the able task of doing it so ably about this Dr. Smita Advani Memorial Oral Paper Competition. Over to you, Anand.
Yeah, thank you, sir. So we move on without delay into the second half of the abstract presentation. We just heard 3 abstracts, and now we will hear the another 3 abstracts. The first abstract is going to be presented by Dr. Shravan Kumar from Tata Memorial Center, and his paper is on the outcomes of CML-CP with generic imatinib. Shravan, are you there?
Yes, sir.
Oh, you can start.
Can you hear me, sir?
Yeah, we can hear you. Please go ahead.
Good afternoon, everybody. So, next slide, please. So, coming to the CML, so we have the Indian data. CML is one of the most common adult leukemia in our population, which usually accounts for 30 to 60% of all adult leukemias. And in our population, usually the younger age is the most common at presentation, and usually the male preponderance will be there. And a study conducted by Bansal et al. Group have reported that those patients who are presented at late chronic phase have the higher incidence of resistance and poor outcomes. Next slide, please. So we know imatinib was discovered in the 1998, and it has revolutionized the treatment of CML patients almost in such a way that the life expectancy has matched with that of the general population. Next slide, please. So coming to the innovator versus generic imatinib, innovator imatinib exists in the beta crystal form, whereas most of the generics were in the alpha form. And when to begin with, Gleevec, when it was launched, it has a cost of around $2,200 per month. And reports from India, where we are using generic imatinib since 2006, found no difference in either efficacy or safety. Next slide, please. So coming to the studies, so there are various studies were conducted on generic imatinib usage. There is a group of Malhotra et al. Who analyzed the plasma levels of original and generic imatinib molecules, and he has correlated with the respective molecular responses. So he found no differences between the both of the generic and as well as original molecules. In a similar way, Eskajan et al. Also conducted one study between innovator and generic imatinib, and he found no difference in the efficacy and tolerability also. Next slide, please. So this particular study conducted by Alvan et al. From Iraq, he used the innovator molecule for a median duration of 4 years before he switched to the generic brand. So on switching to the generic brand, he found that there are 17.5% people have lost the CHR rate, and 17.5% were progressed within 3 months. On switching to the generic molecules, he reported that 8% have restored the complete hematological response. Next slide, please. So coming to the this particular aspect, why we have done this study. So we have seen that there are studies from both negative and positive sides. We don't know where we fall. So we have undertaken this study basically in a country like us where we are using generic imatinib most of the times. We don't have the enough data. And if we use the innovator molecule for a long-term basis, it puts a significant financial burden on our healthcare system. Next slide. So our aims and objectives in our study included were efficacy, toxicity, and tolerance of generic imatinib assessment, and comparing the efficacy and toxicity of this generic imatinib against the innovator imatinib. And we are also analyzed the PFS and OS rates on 1 to 5 years of generic imatinib usage. Next slide. So our primary endpoints were included measures of efficacy, CHR, early molecular response, MMR, DMR, and complete cytogenetic response. And survival analysis were included EFS, PFS, and OS. And coming to the secondary points, which were hematological toxicity and development of imatinib resistance. Next slide. So it is a single-arm retrospective open-label study, which was conducted at Department of Hematology, and period of recruitment is from 1st Jan to 31st of December 2015, and period of follow-up is from 1st Jan to 20th Feb 2018. Next slide. So we have included patients who are diagnosed as CML as per WHO criteria, and they are offered treatment with TKI. Those patients who are presented with APR BC at presentation are patients of CP patients who are treated with innovator molecule were excluded from the study, and responses were evaluated as per the DLN 2013 criteria. Next slide, please. So results, coming to the results, we have analyzed at the end 375 people. Median age in our results were 41 years, and male were preponderance, which included 70%, and median WBC count was 173,000, and high risk SOCAL score was reported in 38% of the people, and median follow-up duration was 34 months. Next slide. So we compared our results with historic cohort data from IRIS, DACISI, and INESTENT studies. So if we see the patient population in our study was 375, which is quite higher than DACISI and INESTENT, though lower than IRIS study. And we have a high risk SOCAL score of 38% people we have. And when you see the CHR rate at 3 months, it is around 98%, which is almost matching that of the IRIS study results. And if you see the 18 months MMR rates also in our study, it is 53.7%, almost matching that of the IRIS study. And the only odd thing is in our study is we have a early molecular response, which was reported only in 41.8%, which is odd when compared to the DACISI and INESTENT, where they have the higher early molecular response rates. And when complete cytogenetic response rate in our population was 84% in our study, and which is very quite high when compared to the other 3 studies compared. And grade 3, grade 4 anemia was reported in 9.6%, which is very high in our population. And grade 3, 4 neutropenia was reported in 6.4%. Next slide. So the overall survival of chronic phase patients at 1 year was 98%, 2 years was 95%, 3 years was 90%, and 4 years was 88%. And the mean time to progression was 38.2 months. And in our study, 6 patients were progressed to accelerated phase, and 4 patients were progressed to blastic phase while on treatment with imatinib. Next slide, please. So to conclude, outcomes of generic imatinib in our study were comparable to the innovator imatinib with the respective historical cohorts. And we have the higher incidence of grade 3 anemia in our study. And however, prospective studies were needed to validate this data on a global scenario basis. Next slide. Thank you.
Thank you, Shravan. Now I invite questions from the audience as well as the judges.
I have one single question, Shravan.
Yes, sir.
I wonder, the historical controls are from the literature or historical controls from Tata Memorial Hospital?
Sir, historical controls from the literature only be compared, sir. The IRIS and DACISI and INESTENT.
So you must be having patients who are on Gleevec also as part
Yes,
of
sir.
the GPAP international program.
Yes. Yes,
And,
sir. Yes, sir.
or the recent program called NOVA. Did you have
Yes,
a chance to understand whether that there's any difference in that? You would have had a little over 1,000 patients on that program.
Sir, unfortunately, I have not looked into that data with GPAP and NOVA basis, what you are saying, sir.
Yeah, so
Definitely
you
I
have
will,
your own
yes.
controls. That is what I meant. They are still
Yes,
taking
sir.
imatinib.
Yes, sir.
Gleevec,
Yes, sir.
they are still continuing on Gleevec.
Yes, sir. Yes, sir.
Thank you.
Shravan,
Yeah.
I have a quick question for you.
Yes.
One is, I want you to just tell me that you had a high grade of grade 3 to 4 anemia.
Yes.
Did you look for coexisting nutritional causes for this anemia?
Yes, sir.
Number one.
That's what actually I want to highlight you, sir. In our population, most of the people were found to have nutritional deficiencies, sir. And so that may be the one of the reason for we have the highest rates of anemia in our studies, sir.
Okay, the second question is, you found that the AMR was not corroborating what is being seen in the other studies, while
Yes,
your
sir.
CCYR is equally good or even better. Any explanation
Yes,
for
sir.
this?
Yes, sir. I can explain maybe with this reason, the low EMR rates being because of a high burden of disease at the baseline, sir, which is having high international scale ratio, BCR ABL1 to ABL1 ratio. So that may be one of the reason why we have the a low early molecular response rates, sir. And when compared to the, if you ask about the cytogenetic response rates, sir, we have the good adherence and good dosage maintenance. So that may be the reason why we have the good cytogenetic control response rate at the end of 1 year, sir.
Thank you.
Yes, thank you.
So thank you, Shravan. We now move on to the next speaker. She is Dr. Gadela Lakshmi Dipti from NIMS, and she is going to talk about long-term outcomes of imatinib in pediatric CML patients. Over to you, Dr. Lakshmi.
Good afternoon, everyone. My presentation is on the long-term outcomes with imatinib in the treatment of pediatric CML at our institute. Chronic myeloid leukemia is a rare malignancy among children for which imatinib is a standard of care based on its efficacy in adults. Due to its rare incidence, available data on the imatinib efficacy in pediatric population is less. Next slide, please. These are two studies which are published from our institute in pediatric population, which have shown that the risk scoring system of the adults may not be useful in the children. And the compliance to therapy is a very important factor in predicting the treatment outcome in children. Next slide, please. The aims of the present study is to know the clinical profile of the pediatric CML patients and to study the efficacy of imatinib in them. Next slide, please. This is a single institute retrospective study for which data of all patients diagnosed with CML aged less than 18 years from January 2002 to December 2012 who had at least 8 years of follow-up were collected and analyzed. The classification of the patients into various phases was done according to the WHO classification criteria. Next slide, please. All the patients were treated with imatinib at a dose range of 260 to 340 mg per meter square based on their risk. And this, the response was evaluated using the cytogenetic response because we didn't have the RT-PCR facility during the initial phases of the study period. And the cytogenetic response definitions were taken as follows. Next slide, please. Event-free survival for this study was defined as the time from initiation of therapy to the progression to accelerated phase or blastic phase, or the loss of an established hematologic, cytogenetic, or molecular response. And the overall survival was defined as the interval between treatment initiation and the time to death from any cause. The statistical analysis was done using the GraphPad Prism version 9. Next slide, please. Coming to results of my study. Next slide, please. A total of 99 patients were treated during the defined treatment period, and the clinical characteristics are as follows in the image depicted below. Next slide, please. Among the 99 patients, the majority of the patients belong to the chronic phase group, that is constituting about 87%, and they have shown a male preponderance. Next slide, please. This is an image depicting the risk group distribution among all the chronic phase patients. And we can see in the image that the majority of the patients in the range of 62 to 67% belong to the low risk groups. Next slide, please. This is the image depicting the patients attaining a complete cytogenetic response at 12 months. We can see in the image that around 70 patients have attained cytogenetic response at 12 months. However, 16 patients have not attained. Of the 16 patients, 6 patients had a minor response and 7 patients had partial cytogenetic response. In the patients who had a minor response, we have done dose hike and they have achieved complete cytogenetic response with that. And in the patients who had partial response, we have continued on the same dose, and these patients have attained the cytogenetic response at 18 months. And there were 3 patients, of which 2 had progressed to the accelerated phase and 1 had progressed to the blastic phase. The patients who had progressed to the accelerated phase, in them the complete cytogenetic response was attained with dose hike, whereas the one in the blastic phase have progressed despite the change of therapy. Next slide, please. This is the event-free survival curve of the chronic phase patients, and it can be seen that the 8-year event-free survival was 61%, and the median event-free survival was not reached. Next slide, please. There were a total of 34 events which have occurred, and of the 34 events, dose hike helped to control the disease in 24 patients, and 5 patients required the need for second generation TK to control the disease, and 5 patients have expired despite change due to transformation to blast crisis. Next slide, please. This is the correlation of the complete cytogenetic response at 12 months with the event-free survival. Next slide, please. This is a overall survival curve of the chronic phase patients, and we can see that the 8-year overall survival was 94% in the study group, and the median overall survival was not reached. Next slide, please. Coming to the course of the de novo advanced CML patients, there were a total of 7 patients in the accelerated phase group, and their 8-year event-free survival was 57.14%. And for them, in them, the second generation TK was required only in 3 patients, and the 8-year overall survival was 100%. In the coming to blast crisis, there were a total of 6 patients who presented in the initial blast crisis, and the median overall survival of the blast crisis patients was 30 months. Next slide, please. This is the comparison of the survivals which are occurred in our study with the other international and the Indian data available. Our survivals are similar to the other pediatric data available. Next slide, please. To conclude, the imatinib has shown excellent survival outcomes in pediatric patients compared to adults. Even in de novo accelerated phase of CML, higher dose of imatinib has resulted in good response. Thank you.
Dr. Geeta, thank you for a good presentation, and you've finished before time, so I think we have some more time for questions. Would your results have been better if you have to design a prospective study, if you do a risk stratification in your patients?
Yes, sir. If I have to do a prospective study, I will use the ELTS scoring system for the risk stratification. And based on that scoring system, I will compare the progression-free survivals and the overall survivals of the patients. Sir.
Did you have any dropouts, compliance issues, non-adherence issues in your retrospective analysis?
Yes, sir. There were dropouts of around 10 patients, sir. And some patients have 2 to 3 patients have continued treatment at different centers, and there are some patients who had dropped out for 1 to 2 years and they have come back. And when they have come back, in 2 to 3 patients, the initial dose has helped, but in some patients we required higher doses.
My last question, since you've done a clinical profiling of these patients, and there is a thought process on the biology of the disease in pediatrics and adults, what were the main differences you found in your clinical findings in your pediatric population as compared to the established adult population?
In my clinical profile, I have seen that the presenting WBC counts were higher compared to the adult WBC ranges, sir. And even the spleen size was also more.
Thank you.
Did you find any growth retardation in these patients? I think there was the report
Yes,
from
sir.
Vijay et al.
Yes, sir. Growth retardation was there, sir. I didn't present in my presentation now, but growth retardation was there.
Okay.
General Nair, can I ask a question? Hemant Malhotra from Jaipur.
Oh, hello, Hemant. Nice to hear you and see you. Please.
Yes, sir.
So, just one quick question. Did you find that the side effect profile of imatinib in pediatric patients was more or less than the adults? Did you see any difference?
I haven't compared, sir, but the pediatric patients have tolerated better than the adults, sir.
And any experience with TFR in the children and young adults?
No, sir. In children, no, not done, sir. It is not recommended
Thank you
to
very
do.
much.
Yes, thank you.
So, thank you, Lakshmi, for that excellent presentation. We now go on to the last abstract to be presented by Dr. Lovin Wilson, and he's going to talk about the long-term adverse effects and quality of life with imatinib in CML patients. Lovin, over to you.
Good afternoon, everyone. I'm Dr. Lovin Wilson from Prince Ali Khan Hospital, Mumbai. CML patients now enjoy life expectancy equal to the general population. The ELN 2020 CML guidelines point out the importance of quality of life in CML patients and the proximity of long-term data. With this in mind, we undertook this study. Next slide, please. Next. Aim of our study is to evaluate long-term adverse effects of imatinib in CML patients and its effect on their quality of life. Next slide, please. This is an observational study carried out over a period of 1 year. 120 CML patients continuing imatinib for 10 years or more were enrolled after due informed consent. Next slide, please. Adverse events were graded as per CTC version 5. Quality of life was assessed with EORTC questionnaire and supplement for CML patients. Next slide, please. Coming to results, mean age of the population was the study population was 50.5 years, and about 90% had performance status 0 or 1. Duration of mean duration of treatment was 13.5 years. Next slide, please. About 23% subjects required dose reduction during treatment period. Next slide, please. 25% subjects had comorbidities, hypertension and diabetes being most common. Next slide, please. These are the common adverse effects reported in our studies with GI problems, musculoskeletal and dermatological toxicities, along with fatigue and edema being most prominent. Majority were grade 1 severity. Next slide, please. These are the rare adverse effects noted with like excessive lacrimation, renal calculi, azoospermia, gynecomastia, and gum hypertrophy. Next slide, please. As you can see, most of the functional scales show very high scores, indicating a good overall well-being of the subject. Point to note here is response comparatively lower for question on physical scale compared to the quality of life question. Next slide, please. Most of the symptom score in red and green bars are in the low to mid range, suggesting mild to moderate symptoms. CML specific symptoms like fatigue, nausea, vomiting, and pain are more prominent. Next slide, please. This is based on the CML24 supplement. For symptom burden, 72% admitted having mild symptoms, while 20% had no impact of symptom burden. Next slide, please. Correlating the main questionnaire of ERTC 30 scale with the CML supplement showed symptom burden from the CML supplement negatively correlated with the quality of life scores in the main questionnaire.
Dr. Wilson, can you hear me?
Yeah, hello. Yeah.
Yeah, please go.
Next slide, please. Symptom burden positively correlated with symptom skills of main questionnaire EOTC 30. Next slide, please. Compared to other similar long-term observation studies, we can see that the common adverse effects profile invariably remains same. Thus, commonly expected imatinib adverse effects in most cases remain persistent even with prolonged continuation of drug. Next slide, please. This is a comparison to some of the Indian studies, though they are of comparatively lesser duration of follow-up. Next slide, please. These are two studies looking into quality of life assessed based on EOTC questionnaire. Note the improvement of quality of life scores with prolonged duration of treatment. Next slide, please. The symptom burden seems to be persistent, but with lesser intensity over time. Next slide, please. Only Krishnan and all had used a CML24 supplement in assessing quality of life, and on comparison, as mentioned before, symptom burden seems to persist with gradual reduction in intensity over a period of time. Next slide, please. And to conclude, even with time, CML patients continue to have persistent adverse effects, but majority of them are grade 1 severity. The general adverse effect profile remains the same. Quality of life outlook seems to improve over the long term. Overall, the low-grade frequent adverse effects of imatinib seems to be tolerated very well by most of the patients, and majority enjoy a good quality of life. Next slide, please. Thank you.
Very nice study. Did you ever come across any personal, professional, marital problems also through the questionnaire? I did not see that specifically you mentioned it. Some of them could have had a problem with scholastic aptitude or finding a job or marital relationships, although you said 2 patients had azoospermia. Anything like that?
Sir, no, there was no that part in the questionnaire itself, and we didn't take into the other social aspects in the study, like
So you only
the
studied
income
the
and everything.
physical part of the you are.
Yes, sir. Yes,
Okay,
sir.
thank you. Thank you. Right.
Okay.
Dr. Wilson, you talked about emotional and physical correlation and how it impacts the outcomes. So
Yes,
mood, so a mood swing or a mood impact negatively on the outcomes was due to the adherence with drugs, or a second thing is, was there any predisposition for these people to go into those sort of mood changes, or it was just a de novo finding? Was any attempt made to see that?
So no, so most of them correlated very well with the mood, but mood effect was more in those who have scored more in symptom burden scales. Those having more symptom burden, they, especially in the female population, they tend to have more negatively impact on mood.
You said
Did they have any pre-morbid psychological condition like schizoid or paranoid
sir.
ideation, etc., or was it purely reactive emotional stress?
So most of them, when personally asked out of the questionnaire, they tend to tell that it is more of because of familial issues and other things, that they are more stressed and negative response to the mood questionnaire, impact of mood or questionnaire.
Okay, so it is a general worry about them in the family.
Yes, sir.
Thank you.
Okay, welcome.
Thank you very much. We should move to the next session, please. May I invite the chairpersons for the session, Dr. R. Gopal, Dr. Hemant Malhotra, and Dr. P.S.R.K. Sastry. This is an oration by Professor Tim Hughes, and Hemant has been instrumental in getting this wonderful international faculty for us. So over to you, Hemant, to introduce her.
Thank you very much, Dr. Purvish. Once again, pleasure and privilege to be part of this Dr. Advani's first oncology series activity. I'd like to introduce you to the second orator of this conference, Professor Timothy Hughes. Tim is a dear friend of almost 15 years duration, introduced to me by Dr. Graham Goldman. And we sit on the ICMLF board together, and we meet at least once a year, if not more. Tim is a big friend of India, and he comes to India, or used to come to India before this pandemic business, at least once or maybe twice a year. He is the head of hematology at SA Pathology and consultant hematologist at the Royal Adelaide Hospital. He is also the chair of the International CML Foundation, in which I am a member also. He is an international expert in the biology of and treatment of chronic myeloid leukemia. And he, along with his laboratory head, Dr. Susan Branford, has led the world effort on standardization of molecular testing for chronic myeloid leukemia. The international scale, which you are so familiar with, was initiated in Adelaide and Germany and in England. So Dr. Tim is going to give the second oration, and we're going to play a recording because it's very late in the evening for him. So I hand over the screen back to the organizers for Dr. Tim's talk.
Hello, I'd like to firstly thank Dr. Hemant Malhotra, friend and colleague, who has invited me to give this oration at the virtual annual conference in honor of Dr. Suresh Advani. It's great that I can join you today and share some of the excitement about the progress we're making in chronic myeloid leukemia. It's interesting when we look now at the number of patients who have died over the 10-year period in the large trials. We look firstly at the IRIS trial and the German CML4 trial, and I want to focus on the CML-related deaths you can see in the middle there. So in the IRIS trial, there were 9% of patients who died of a CML-related cause, so presumably blast crisis or bone marrow transplantation. And that's probably the rate that you would see if you only have imatinib available to use in your patients with CML. We then see in the German CML4 study the rate of CMO-related deaths has fallen to 6%. I think that's starting to reflect the fact that that study was a later study where patients could move on to second-generation drugs, in some cases perhaps even third-generation drugs. So there's been a moderate reduction in the number of CMO-related deaths. We then compare that to the number of patients who had a CMO-related death in the INEST-ND study, firstly in the imatinib arm, where you see that rate of deaths has fallen down now to 4.9%, so about half the rate that we saw in the IRIS trial. So I think that does suggest that even though all those patients received imatinib as their frontline therapy, the capacity to switch to a second or a third line therapy has actually halved the rate of death due to CML. And there we then see in the actual study arm, nilotinib 300 milligrams twice daily, that rate of death due to CML coming down now to 2.4%. So it's really halved again. So clearly the using intensive therapy up front has brought us down from a mortality which was already remarkably low of 9% over 10 years down to just 2.4%. So I think that represents the progress we've made since the availability of imatinib going through to the availability of the second and third generation drugs. Of course, the non-CMO related deaths are still a consideration we need to work on. Perhaps we can get those rates lower if we can use these drugs most intelligently and avoid using the more potent drugs in patients with significant comorbidities. And just to remind you about the remarkably strong impact of major molecular response, going back to the IRIS 10-year data, where about 2/3 of the patients did achieve major molecular response by 18 months. And you can divide up those two cohorts, those with and without major molecular response. And you see the number of patients who have died. Firstly, looking at the patients who were not in a major molecular response, leaving aside patients who died of other causes, which is going to be similar in both cohorts, but there were 4.5% of the patients who did not have major molecular response who died a CMO-related death over the subsequent period up to 10 years, whereas there was not a single death amongst the large cohort of patients, 164 patients, who achieved major molecular response by 18 months. So clearly, that remains a very, very desirable target for our patients if we're focusing on minimizing the prospects of CMO-related death. I now want to turn attention to treatment-free remission. Because we have really minimized the problem of CMO-related deaths, the new focus of our therapy is going to be treatment-free remission. And that's been reflected in the European Leukemia Net 2020 recommendations. And this is a quote from those recommendations. The panel agrees that treatment-free remission is a significant new goal of CML management. Treatment may be changed to a second-generation drug if a patient's on imatinib to improve the depth of response in selected patients in whom deep molecular response has not been reached. That's actually quite a large step forward for the ELN. It was an area of great debate as to whether patients who were traveling along optimally with a major molecular response could in some cases be switched to a more potent drug in order to achieve deep molecular response. And that was, in the end, the consensus of the group. In addition, we agreed that we recommend consideration of treatment-free remission in appropriate patients after careful discussion, employing the concept of shared decision-making, which I think is always going to be important with our patients. And if you look at the overall guidelines for treatment-free remission based on the ELN 2020 recommendations and compare them to the US NCCN recommendations, they're actually really well aligned now. They agree that patients need to be in chronic phase and have never had accelerated phase or blast crisis to be considered for treatment-free remission. They agree that motivated patient is critically important. High quality PCR with rapid turnaround. You need to have a transcript that's measurable by the international scale. You need to have a patient who's either on first line therapy or second line if intolerance was the reason for switching. I tend to disagree with that. I think there are some patients who switch because of a warning, who would still be perfectly suitable for attempting treatment-free remission. But this is the consensus from the ELN and the NCCN. They both agree that you need to have a deep molecular response, that is at least MR4, for at least 2 years. Now, there is some difference about the duration of the TKI therapy. The ELN says that at least 5 years of imatinib and at least 4 years of a second generation drug is mandatory, whereas NCCN would regard 3 years of a TKI as being mandatory. And when you come to optimal, which is the next step, so that's saying these are patients where we're very comfortable proceeding with an attempt at treatment-free remission, there is once again some difference in the duration of TKI therapy that's recommended, but complete consensus that patients need to have had at least 3 years of MR4 and at least 2 years of MR4.5 if that can be assessed. So I want to take a case to sort of illustrate some of these considerations. This is a 54-year-old male with chronic phase CML, diagnosed in 2015, and had an intermediate ELTS score. The ELN 2020 does recommend that ELTS score is now used rather than SOCAL, if at all possible. I think that's based on good evidence, but I won't go through that today. We also assessed the Framingham risk score, which is the cardiovascular risk score, and this patient was assessed as low risk, and I'll show you why a little bit later on. So intermediate ELTS risk in terms of their CML risk, and low Framingham risk in terms of their vascular risk. So for that reason, he was treated with nilotinib at the standard frontline dose of 300 milligrams twice daily. And in fact, he had a very good response. I'll show you the actual data in a moment, but he achieved an MR4 or a level below 0.01% after 18 months or 1.5 years. And in fact, after 5 years of therapy, he's maintained MR4 for 3.5 years. So here's the actual data where you can see the PCR results shown on international scale according to the months of therapy. And what I've shown in the color code is when they achieved MR4 and when they achieved MR4.5. So 3.5 years of MR4, 2.5 years of MR4.5. So this patient is actually keen to attempt treatment-free remission if and when we recommend it. Now, there are some vascular concerns with this patient. His younger brother just had a coronary stent inserted, and the patient is now being treated for hypertension and hypercholesterolemia. And this is not uncommon in our patient group, in this sort of age group. The hypercholesterolemia is probably to some extent exacerbated by the nilotinib, and hypertension becomes a common issue in this setting. So would you recommend treatment-free remission now? And at this point, I'd like to suggest that there are 6 questions that I tend to ask when I think about whether treatment-free remission is the appropriate way to go forward with a patient. Firstly, and perhaps most importantly, are there any contraindications, either relative or absolute? And absolute contraindications would be history of advanced phase disease. Relative contraindication might be a prior TKI failure. And I think an atypical transcript that you can't measure accurately would be an absolute contraindication. Is there any urgency? We'll deal with that in a moment. Importantly, are they motivated to attempt treatment-free remission? This particular patient is motivated. Are they emotionally and mentally resilient? Because it can be a traumatic thing to go through. And the patient wants to know, what are the chances of success now? And what are the chances of success if we delay by a year or 2? So just thinking about this question of urgency, I think in this particular patient, we need to be aware of the fact that they're on nilotinib therapy, and we have very well documented data on the vascular risk associated with nilotinib. And we do believe that the risk is also present for dasatinib, perhaps at a similar level. And we don't really know for bosutinib, it may be less. We don't really have the data to know for sure. But clearly, the data is very well documented for nilotinib. This is the data over the first 5 years, where the percentage of patients who had a cardiovascular event, and that could be a coronary or cerebro or peripheral vascular event. You can see in the imatinib arm, it's just 1.8%. It increases to 7% for the standard dose nilotinib, and even higher than that for the higher dose nilotinib. And what about for the next 5 years? Well, I was hoping that the rates of events might be actually lower with nilotinib because we're getting better at identifying these risk factors and addressing them. But in fact, in the INEST-ND study, which is where this data comes from, the rates were quite similar in the second 5 years. So that once again with imatinib, it's a low rate of just 1.8%. But with the nilotinib 300 twice daily, there's still 9% of patients who've had an event between 5 and 10 years, making a total of over 16% over the full 10 years. Now, going back to this Framingham risk category, just to remind you how we calculate that. So it's either high, intermediate, or low according to the points. And you get points according to your age, your cholesterol, your blood pressure, and whether you're a smoker or a diabetic. So this particular patient was 54 at diagnosis. They had mildly elevated blood pressure. So the 54 would give them a score of 8, and the elevated blood pressure would give them a score of 1, as I've circled there. So their score was 9, which would still give them a low Framingham risk category. And that's actually quite reassuring because we know that patients with a low Framingham risk score, even with nilotinib, the risk of a cardiovascular event is actually quite low still. You see there with imatinib in the low Framingham risk group, 1.1%, whereas with nilotinib, 1.7%. So really, that to me is quite reassuring. By contrast, the patients with a high Framingham risk, it goes from 3% up to 17%. That's a significant concern for those patients. But that's the 5-year data. What about the 10-year data we now have from INEST-ND? Well, you can't be quite as confident about the low Framingham risk group. We now see 1.1% over the 10 years for imatinib in the low risk group, but 7% in the nilotinib cohort who had a low Framingham risk. And clearly, you see the figures there for the intermediate and high risk groups as well. But for the purposes of this particular patient consideration, we start to get nervous about even these patients with a low Framingham risk score treated with nilotinib beyond 5 years. And of course, this patient now is 5 years older. So rather than scoring 9, he'll score 10 for his age. He's now got an elevated cholesterol and his blood pressure is now on treatment. So he scores a 10, a 3, and a 3, a total of 16. He's actually now an intermediate risk category. So going back to the recommendations of ELN and NCCN, this patient would actually qualify on virtually all of those considerations, except perhaps he's only had 5 years of total TKI drug. And the NCCN would say that ideally, they'd like to look at least 6 years. But let's look at this question about what are the chances of this patient having success now? I think we now have some new information that would be very helpful in that regard. And that comes from a recent study that we've just published in Blood, looking at the predictors of successful treatment-free remission. And this is work conducted in our laboratory by our CML fellow, Narani Shanmuganathan. So these were the risk factors that she found were most important in terms of determining whether a patient who was eligible for treatment-free remission would actually have maintained treatment-free remission. So for this, the criteria was still being off drug in major molecular response at 12 months after stopping. We found that, first of all, the halving time, which I'll describe in some detail in a moment, was by far the best predictor, both at the univariate and at the multivariate criteria. We also found that the transcript was predictive. Having the longer transcript, E14A2, was predictive of success. We found that duration of drug was also important. And we didn't find that the time from treatment to the achievement of MR4.5 was predictive in the multivariate analysis, nor was, interestingly, the 3-month BCR-ABL value. So even though the halving time was predictive and highly predictive, the actual value of BCR-ABL at 3 months was not predictive. So let's look at this halving time concept. So here are 2 patients. One goes from 100% down to 10% at 3 months. One goes from 100% before they started therapy down to 0.1% at 3 months. Well, the halving time can be calculated as 27 days for the first patient and 9 days for the second patient. But what about these three patients? They all had the same value at 3 months at 1%. But one patient had a starting value of 300%, one was 100%, and one was 10%. And because of that starting value, their slopes are quite different. So here we have halving times of 11 days, 14 days, and 27 days. So in other words, a patient who goes from 100% down to 10% has the same halving time as a patient who goes from 10% down to 1%. And we see that the range of halving times in our patients is somewhere in the range of 7 days up to about 30 days. And what we found was that patients who were eligible to stop and stopped, and they either maintained a treatment-free remission or they relapsed, when we looked at their halving time from the first 3 months of therapy, in some cases it might have been 10 years before they actually stopped drug, but it still had an incredibly strong impact on the likelihood of success, so that patients who were able to successfully achieve treatment-free remission had a median halving time of around about 10 or 11 days, whereas patients who relapsed, it was over 20 days. You can see the data there, it's quite convincing. So then we narrowly looked at the patients according to their halving time quartiles. So if you have a quartile which is in the upper quartile, Q4, that is greater than 21.8 days, that even though you achieve a deep molecular response and you're eligible to stop, the chance of success when you stop are only around about 10%. Whereas patients who have a halving time below 9 days, the chance of success are better than 75%. So this is incredibly valuable when you're deciding which patients you feel comfortable stopping and which patients you feel need to continue on for longer. So we prepared this chart where you can actually put the halving time on the chart and calculate the chances of success for a patient who is eligible for treatment-free remission attempt. Now, this is assuming they've had 3 years of MR4.5, because that's the median figure for the patients that we've followed in Adelaide. So for this particular patient, they went from 290% at diagnosis down to 0.26% at 3 months. So their halving time was 9 days. So in fact, if you chart 9 days on this chart, you'll get a 75% probability that they'll be successful when they stop as of today. So that to me is very, very reassuring for this patient. If you can tell the patient their chances of success is 75% rather than saying it's 50-50, it's a lot clearer indication for the patient to stop today rather than continue therapy. The other valuable data is whether they have the longer transcript, the E13, or what we used to call the B3A2 versus the B2A2, or now called the E13A2. You can see that having a longer transcript actually gives you a more than 20% better rate of treatment-free remission. And this is considering patients who are eligible to attempt treatment-free remission. And this is actually exactly the same as the figures that were derived from the UK group, the Hammersmith group, and they were the first to discover this relationship. This is actually showing relapse rather than treatment-free remission, so it's the opposite, but the numbers are the same. We found exactly the same, that about 1/3 of the patients relapsed if they had the shorter transcript, whereas 2/3 relapsed if they had, sorry, the other way around, that only 1/3 relapsed if they had the longer transcript, 2/3 relapsed if they had the shorter transcript. It's better to have a long transcript. So our recommendation to this patient was to stop now. But of course, patients don't always do what you tell them to do. And this particular patient said, well, he'd rather continue a bit longer. So then you have to consider, is it appropriate to continue their therapy at 300 twice daily of nilotinib and to optimize their risk factors for vascular disease, aiming at one day to attempt treatment-free remission? Should you switch them to imatinib to modify their risk of a vascular event, or should you reduce their nilotinib dose, or even switch to low-dose dasatinib? Actually, what we did was to reduce the nilotinib dose to half. And I think that can be quite effective, and it nearly always maintains the depth of response. And it's quite consistent with what was done in the Destiny study, where they looked at halving the dose for a year before they stopped therapy. So coming on now to this question of whether older patients have a higher chance of achieving successful treatment-free remission. Now that's come from, initially from the Italian group. They found that the age of the patient And also a digital PCR, which I won't go through in detail today, can predict whether a patient will relapse when they stop therapy. This is the ISAB study. And they published this 5 years ago. They showed that 95% of patients who were less than 45 years old relapsed, and 42% of the patients between 45 and 65 relapsed, and only 33% of those are over 65. They showed this really strong relationship with age. And that was supported by the Hammersmith group, where they showed, as well as the data I've already shown you about the transcript being predictive, they showed that age was predictive as well. And in fact, they're using that to make a score to predict treatment-free remission. So we looked at in our cohort of patients, we have 115 patients who've attempted treatment-free remission, and the median age is 60.9. And we found that our median age in the patients who were unsuccessful was 61, and the patients who were successful was 59. So we didn't see any difference at all. In fact, if you look at the age range in the patients who maintained treatment-free remission and in those that relapsed, we didn't see a difference. So I don't know why our data doesn't support the data from the Italian and the Hammersmith group, but that's an interesting question for discussion. But there has been a meta-analysis last year. We're looking at over 1,500 patients who've attempted treatment-free remission, and they didn't see a difference according to the median age of 56. Above and below that, both had similar rates of successful treatment-free remission. So that remains to be worked out further. I want to finish by just showing the data from Adelaide, where we've been following now over 300 patients, and this is showing the cumulative incidence of being eligible for treatment-free remission, that is having at least 2 years of MR 4.5. You can see that by 15 years, we're getting well over about 2/3 of our patients are eligible for treatment-free remission. How many have attempted treatment-free remission? Well, just about all the patients who were eligible. There's a few that have been reluctant to go ahead. How many have been successful? As you might expect, it's around 50 to 60% of those that have attempted. So now, with a cumulative incidence over 15 years, we're getting around 40% in a successful maintained treatment-free remission. So I don't accept the premise that I often hear that only 15 or 20% of patients can really get to treatment-free remission. With a very proactive approach and with using all of the available drugs, if at all possible, you can get, I would think over the next 5 to 10 years, a majority of our patients into treatment-free remission. So in finishing, I'd like to take this quote from the ELN 2020 recommendations. The goal of therapy is normal survival and good quality of life without lifelong treatment. That expresses our need that we want patients to have good quality of life and ideally off drug. And the vision for the next 5 years is that more CML patients will successfully achieve treatment-free remission, and that it'll be possible to talk more confidently about the curability of CML. I think it's a great way to finish the recommendations. So just to sum up some of the key points, the ENEST-ND 10-year data shows that the cardiovascular event rates on nilotinib remain high in the subsequent 5 years, not just in the first 5 years. And that even patients with a low foraminal risk score, while they have a low risk of events in the first 5 years, it becomes significant in the second 5 years. Also, I've shown you data that suggests, and it was validated by the Korean group, I didn't have time to show that data, the tempo of the initial response, and we measure that by halving time, is a very good predictor of subsequent successful treatment-free remission. So you need to consider very carefully, if you're using second-generation drugs, the vascular risk that you're exposing your patients to versus the improved prospects of treatment-free remission, and make a patient-specific calculation as to whether you want to continue your second-generation drug in a patient under that setting. Treatment-free remission is now the mainstream goal of therapy, but it's critically important that you adhere to the strict institutional conditions, particularly around the quality of PCR monitoring, and you adhere to the eligibility criteria that I've set out. Age is a critical consideration for treatment-free remission priority, but even older patients may benefit from treatment-free remission. You just have to be more careful about their comorbidities when attempting to achieve a deep molecular response. The halving time, the transcript type, and the duration of the TKI or the duration of the deep molecular response can all provide critical guidance to treatment-free remission considerations. I'd like to finish by acknowledging the excellent work from Narani Shanmuganathan, and also co-supervised by Sue Branford in the laboratory, my other collaborators in Adelaide and around Australia, and my colleagues in South Korea who validated our halving time data, Dr. Dong-Wook Kim and Dr. Park. And once again, thank you for allowing me to join this wonderful meeting, and I hope it goes extremely well. Thank you very much.
Thank you very much, Tim. That was a fantastic exposition, and it is really great. A couple of questions. One is regarding the cardiovascular risk for patients with nilotinib. So if you have a patient with nilotinib, do you do a special evaluation of the cardiac status at follow-up?
Yes, it's a really important point. For all patients on second generation drugs, we've been doing serial ABI, so ankle brachial index, and that's quite a good and sensitive way to look for progressive atherosclerosis. We also do Dopplers of the legs, and we're very careful to inquire about any suspicious symptoms. Whether we should be doing more than that, calcium scores potentially. I think it just needs to be, be very aware of the fact that even though you may be happy that you're controlling the cholesterol and the patient's adhering to a reasonable diet and exercise, the data is significant in that second 5 years. So I wouldn't continue nilotinib and possibly even dasatinib beyond 5 years unless I had a target of treatment-free remission in front of me. If you're not going for treatment-free remission and you've achieved a deep response, you're not gaining very much by using a drug with more toxicity than imatinib.
Very true. Let's assume that we are aiming for treatment-free remission and the patient is now off the therapy. How frequently do you monitor them? And in case there is an indication of the disease coming back, is reinstitution of the same drug at the same dose equally effective?
Yeah. So I think everyone agrees that ideally monthly for the first 6 months, 2 monthly until 12 months, and then back to the more routine 3 monthly is appropriate. There's some slight difference between NCCN and ELN, but I think that's a good recommendation. We did look at doing a little bit less rigorous monitoring, and we published in Blood last year the idea of that it could be possibly 2 monthly would still be adequate. But once patients become positive, it's much better to do it monthly, because when they go up very quickly, and you don't want to wait until they lose their hematological response before you restart drug. It can then take a very long time to get them back under control.
Right. And the same drug at the same dose, is that usually adequate when we have to restart?
Look, we nearly always restart the same drug because we know that they were tolerating that drug. They usually have a supply of it in their cupboard. So we can ring them up and say, your level is 0.12, back on drug, we'll talk to you next week. We haven't got to, go and get new drug supply, etc. But that doesn't mean we're going to commit to that drug long term. Generally, you'll find you'll get them down to a deep response. If it was imatinib originally, back on imatinib, you'll get them down. 95% will go back down to a deep molecular response. But the question of whether they would be better off on a more potent drug or even with the addition of interferon, these are questions that we need to address, because second attempts at treatment-free remission, while they can be successful, the success rate overall is 30–35%. So we probably need to do something better in that cohort. And it may be that if patients who were unsuccessful on imatinib, you may do better on a second-generation drug, but no one's really demonstrated that yet.
Right. One last question. What about pregnancy? If a young lady wants to have a child and she is in treatment-free remission, or she has responded well to the initial treatment, what should be our strategy?
Well, ideally, I'd like to do it in the setting of treatment-free remission. And if I can persuade them to hold on for that, that's fantastic. If that's not possible, if, sometimes you're talking to a 40-year-old who feels that they don't have the luxury of time. So you have to make compromises. I try and work that out with them, make them understand that stopping drug when you haven't achieved major molecular response is substantially risky. Stopping drug when you've achieved and maintained major molecular response for several years is starting to get less risky. And so I think it's a matter of weighing up that risk versus that potential benefit of having having another child. And it's a really tough decision. And I think all you can do is give them the best information you can about the risk and the reality that they may be taking some risk to their own health, but in some cases they'll be willing to take that. As long as they understand that, it's acceptable.
Is imatinib safe during pregnancy?
No, we don't use any TKI during pregnancy. I know there is some data from the Russians and from the South American groups, and I don't know, you may have some data yourself, using a TKI during the 3rd trimester. I think imatinib has been used, and I don't think there's any strong evidence that it's adverse in that setting. It's clearly adverse in the 1st trimester and the 2nd trimester, but I think there are some cases where where clinicians have used it in the 3rd trimester. We haven't done that, and I wouldn't recommend it, but in some cases you may have to weigh up the risk to the patient versus the risk to the fetus, and it may be justified, but there's not a lot of data in that setting. And certainly dasatinib, there's some very worrying data about its use in any trimester, so I would not use dasatinib in any pregnant woman under any circumstance.
Right, perfect. Thank you very much, team. On behalf of Dr. Hemant Malhotra and Dr. Suresh Advani, once more I appreciate the time that you have taken in sharing your expertise on CML, and I'm sure that all of us have benefited immensely from that. Thank you very much.
Thank you very much.
Thank you. Can we request Anand to declare the results of Dr. Smita Advani Memorial Competition, please?
Yeah, thank you, sir. Sir, the first prize of the first Dr. Smita Advani Oration abstract presentation goes to Gadela Lakshmi from NIMS. The second prize goes to Dr. Rajan Kapoor, and joint 3rd place winners are Dr. Shravan Kumar and Dr. Aditya Elhens. So I congratulate all the winners and all the presenters who presented their wonderful abstracts. I also thank the judges for their valuable time and the patience to judge all these abstracts. And I thank Dr. Purvish Parekh for arranging everything. So the first prize is a cash prize of 15,000 rupees, and all the winners get a certificate. Thank you. Thank you, everybody.
Thank you. Can we request Dr. Advani to give the concluding remarks? Sir, you will have to unmute yourself.
Yeah, good evening. I'm sure all of you must be tired, but we are so much enriched with our knowledge from all the lectures and debate that we have heard. And I'm sure many of us will really go and do much better service to our patients with chronic myeloid leukemia. This, again, I'll thank Dr. Purvish and his team who have done a wonderful job to put up this program on chronic myeloid leukemia. Thank you very much. Thanks to all of you over there. Thank you.
Thank you very much, sir. And we will now close the meeting. Thanks everybody who is present. And Kavina Creations, you can now shut the meeting. Thank you.
Thank you so much, sir.
Thank you.
Thank you, sir.
Thank you.
Thank you, Dr. Advani. We'll meet next year, same time, sir.
Okay.
Thank you, sir.
Yeah, definitely.
Salam, sir.
Okay, thank you.